Okay, we're ready to start. So welcoming you to the meeting of the North East and North Cumbria Integrated Care Board on 3rd of June 2025. I'm Liam Donaldson, the chair of the board. We would also like to welcome members of the public in the room and also those who are online. We have apologies for absence from one of our partner members, John Pearce, and Ken Bremner, another of our other partner members, will be leaving at lunchtime. So just before we start on the agenda proper, I'd just like to make two announcements. First of all, one of our independent non-executive directors, John Rush, has stepped down from the board in order to pursue a project in health, and he's been a very, very valuable member of the board from Cumbria, of course, chairing one of our board committees, but also a very active board member with a great depth of experience of health and healthcare in the North East and North Cumbria. So we've thanked him very much for his service and look forward to keeping in touch with him at a social level. I'm sure we will. So thank you to John, and we'll record that in the minutes. We're also saying goodbye today to Graham Evans, one of our executive directors. Graham has he's the Chief Digital and Infrastructure Officer, and today's his last meeting of the board. Graham has had 21 years of service in the NHS and a 46-year-long career more generally. So it's saying goodbye to somebody who's dedicated a very substantial proportion of their professional life to the NHS. I first talked to Graham, or met Graham, in the COVID era, where we didn't know we'd never met each other face to face, but he was one of the people that I called early on when I was taking up the shadow role before the ICB was statutorily formed. And Graham at the time was based in the Tees Valley and also was responsible for coordinating a lot of our digital work on behalf of what was then the integrated care system, which wasn't a statutory body, but they were formed around the country of partners. And I have to say that the conversation I had with Graham was not only clear in explaining the complexity of where the NHS was going on digital and data, but also very inspiring, talking about, first of all, the excellent things that were already being done, but also some of the things coming onto the horizon, which Graham had a very deep knowledge of. So I was absolutely delighted when he was appointed through a competition to the board and was able to bring his expertise of the North East and North Cumbria, but also nationally and internationally. So it's been a great privilege to have Graham on the board, and he's an unusual combination in that he's someone, when I talk to other people, who's always talked about with great affection, but also with great respect. And to have affection and respect in the same person is quite unusual in my experience. So Graham's been a special person and we'll really miss him. I challenged him over coffee as to what he was going to do next, and he's being unclear about that, which is very good. You shouldn't make any quick decisions. But I do know from previous knowledge that Graham is a talented drummer, and no doubt will be continuing that side of his non-NHS life. But, you know, I like to think that in an alternative universe, it might have been John, George, Paul and Graham. So good luck, Graham. We'll miss you, and thank you for everything you've done for us. So we move on now to declarations of interest, and there's quite a long list of declarations, and I think we should probably get that out of the way now, but it comes up predominantly on item 9.1, but Deb Cornell, our Board Secretary, will read out the list.
It does, thank you, Chair. Yes, sincere apologies, I have a list as usual in relation to this item, so if we could note the following for the minutes. So in relation to County Durham and Darlington Trust, we have Neil O'Brien and Ken Bremner. Gateshead Health Trust, David Chandler, Kelly Angus and Ken Bremner. Newcastle upon Tyne Hospitals Trust, Levi Buckley and Ken Bremner. Northumbria Healthcare Trust is Sam Allen and Ken Bremner. South Tyneside and Sunderland Trust, David Chandler, Syra Malik and Ken Bremner. North Tees and Hartlepool and South Tees Hospitals Trusts is Ken Bremner and Graham Evans. North Cumbria Integrated Care Trust is Ken Bremner. Tees, Esk and Weir Valley NHS Trust is Rajesh Nadkarni, Tom Hall and Ken Bremner. Cumbria, Northumberland, Tyne and Weir Trust is Rajesh Nadkarni, David Chandler, Hilary Lloyd and Ken Bremner. North East Ambulance Service is Ken Bremner and Graham Evans. And finally for South Tyneside Council it's Tom Hall. And just to note that the details of the individual conflicts are on the register, which is on our website, and the noted individuals can take part in the discussions but not the decisions. Thank you, Chair.
Thank you very much. Any points anyone wants to clarify with that? No. And then the next item is to confirm that we're quorate. We are. Thank you. So it's minutes of the meeting, the previous board meeting held on the 25th of March 2025. Are there any points of accuracy that anyone wants to raise? No, thank you. Well, we approve those as a true record. And then the matters arising, which are contained in an action log. Are there any follow-up points that any members of the executive team want to report on? Are there any questions or comments that any members want to make? No. So we move on from that. Are there any items of other business that anyone would like to add to the agenda? Okay, so we go with the agenda in its present form. And now moving on to the Chief Executive's report, and Sam Allen, our Chief Executive, is going to give that.
Thank you very much, Salim. Good morning, everybody. So I will take my report as read, but I just want to go through it and pull out a few key items. And there are 3 areas that aren't included in my report that I just want to bring to the board's attention as well. So first of all, you'll see in my report a summary of the current work underway that's been mandated by NHS England and the government for ICBs to transition to become what they're calling strategic commissioners. We have got a separate item on that following this report, so I won't comment on that at this particular point in time, Chair, but suggest we cover it then. In my report, I do a brief look back over the last year. We will be bringing our annual report through to the board in due course, but I do think it's important as a board for us to, I think, look back and recognise that we did deliver our operating plan for 24-25, and that included a surplus of £12.12 million for the ICB and an underspend on ICB running costs, and in part that underspend on the running costs and the work that we did last year on organisational changes has positioned us relatively well in facing the changes that we'll come on to talk about through the transition programme. We did use our surplus to offset pressures within provider organisations in the system, and it did result in a small surplus, and that has been subject to final audit. So whilst this is extremely positive, and of course delivering our plan means that we start the year in the best possible position, as I've reported to the board previously, this financial year we've got an incredibly stretching and challenging plan, and in part this is due to the level of non-recurrent benefits supported in the position during 24-25, and also what we know is lower than average growth for the ICB in financial terms for this year. So What does this mean in practice? It does mean that we've got significant additional efficiencies to make, and across our NHS organisations in the integrated care system, this is between 5 and 8% of turnover per organisation. I think this is at a level we've certainly not seen previously. It's incredibly stretching. As I said, we do have plans in place, and we have submitted a financially balanced plan to NHS England, and they have now approved and signed that off. We do continue to do work right across our system to address the unmitigated financial risk in our plan, and when we come on to our financial report, our finance director, David Chandler, will cover that. I would say that I think we're working really well as a system on this across many areas, and I think this is also supported by our Foundation Trust Provider Collaborative, where we've got joint programmes of work across our system on areas such as workforce. One area on workforce that I'll ask Kelly Angus, our Chief People Officer, to cover following my summary of the report is a letter that arrived over the weekend to all NHS trusts and integrated care boards from the Secretary of State for Health and Social Care and Sir Jim Mackey, the Chief Executive of the NHS, requesting that we go further on reducing the use of agency staffing and therefore the spend on agency services across the NHS. We know that many millions of pounds are spent on agency staff, and of course a percentage of that funding goes as a direct premium into the pockets of the agency, and this is many pounds that could be better used within the NHS. Having said that, we know that workforce supply remains an issue across healthcare globally, and therefore this will require some really concerted effort to build our own temporary workforce and indeed support the continued recruitment and retention of our clinical, predominantly our clinical workforce across services. And I've asked Kelly to cover a summary of where we are across our system, where we've reduced agency spend, and we have made good inroads to that over the past year, but of course what more we've got to do this year, and I'll come to Kelly in a moment for that. As well as looking back over the last year, you'll see my report includes a number of highlights. I do want to commend our local delivery teams and the Integrated Care Board, who throughout a year where we have had ongoing internal change, they've maintained a strong focus on integration and partnership working with local authorities, community providers and the voluntary and community sector. You'll see a number of areas that they have led within my report, and just picked out a few highlights really. Firstly, the 40 ARI hubs, the acute respiratory infection hubs that were set up across the organisation. This actually delivered another 51,000 appointments to our communities, highly successful, and I'm delighted that we've now built in ARI hubs as a feature of our urgent and emergency care system going forward. You'll see that we undertook a system-wide improvement programme with the support of Aqua to reduce ambulance handover delays, and whilst we do have further work to do there, we've had good success over the past year, and I'm delighted at this current point in time, and you'll note in our integrated performance report we are number 1 in the country for category 1 and category 2 ambulance response times, and again our ambulance service is to be commended for that, but also working with all of the NHS organisations, the emergency departments, and indeed the many clinical call handlers who are responding to the public through NHS 111. Delighted that in the past year we've been able to open further mental health safe havens, and these serve as alternatives to the emergency departments. We've opened safe havens in Ashington, Newcastle and Gateshead, with further developments planned. And we've also fully implemented the right care, right person approach, working closely with all of the police forces covering the force area. One of the areas I'm hugely proud of that we've made inroads to, and I think really recognises also the work that we've been doing around housing and healthcare programme, is the 10% reduction of people with learning disability and autism who've been in hospital, and many of these individuals have and we do have a number still, but are placed in hospitals many hundreds of miles away from home. And not only have we received a 10% reduction in those placed in hospital, 10 of those individuals have been in those hospitals for over 5 years, and they're now back, many in their own homes, back in their local communities, and able to have those ongoing relationships and reconnect with their communities, their families and their friends. It's just simply life-changing, and is a result of a huge amount of work. And the connection with the Housing, Health and Care programme is that programme positioned us really well to secure £8.5 million worth of capital that we've utilised in order to secure those homes and facilities. I do particularly want to recognise the partnership with Every Turn, who are a third sector mental health organisation, in supporting us with those repatriations of those individuals back to their local communities, and we remain committed to continuing that work. Within my report, you'll also see that as commissioners, we've been given some new provisions as commissioners, particularly when it comes to planning activity with providers of secondary care services, and putting plans in place for them with assumptions. And you'll see in my report that we have explored these, and we intend to utilise these new powers that we have as commissioners to set minimum waiting times for some pathways of care. Whilst we have incredibly good access in areas such as eye surgery, particularly in the independent sector, where we're seeing waiting times as short as 2 weeks, we know that in some of our pathways of care across some of our other providers, we see much, much longer waiting times. We do only have a finite resource, and it's up to us in terms of how we plan to use that resource to make best use of it. So we are seeking to put in place minimum waiting times of 11 weeks on some pathways of care. And what that will enable us to do is to redirect some resources into pathways of care where we have much longer waiting times. I'm sure that will be an area of interest to the board. Within my report, you also see mention of the Boost Learning Academy. Delighted that we now have over 15,000 members as part of our learning and improvement community. And that doesn't just include people in the North East, North Cumbria, it includes people all over the country and indeed in other parts of the world. This collaboration and focus on improvement is getting a lot of interest from other areas, and how we build in improvement methodologies. We had colleagues present recently at the Institute of Health Improvement International Conference on this, and again we've been able to use our learning and improvement community in areas through communities of practice such as the Housing, Health and Care programme, the ambulance handover improvement, and other quality improvement areas such as all age continuing care and supporting proactive and frailty care as well. So that's an important development that I think really looks to frame the work that we do through a continuous improvement approach. And Chair, just the other two final areas I wanted to mention that aren't covered in my report today. Firstly, the Better Care Fund. We spend about £343 million with our local authorities in partnership with them through the Better Care Fund, and our local delivery teams lead the work on working with our local authorities to put those proposals together. I'm delighted that our plans for this year have been signed off, and I'd like to ask Levi to say a few words about that, and particularly about how we monitor delivery of the Better Care Fund. The vast majority of these resources seek to support people to maintain their independence in their own homes, reduce the reliance on hospital-based care, and therefore it's really incumbent upon us to make sure that we've got good tight processes on how we're monitoring the best value of that resource in terms of the outcomes that it is achieving. And then finally, the board will be aware that we've received a request from NHS England that in this financial year we look to invest some further funding in the delivery of mental health support teams in schools. We are already committed to invest quite a significant amount in mental health support teams in schools, and we remain committed to achieve the national requirement for full coverage and implementation by 2029. To invest further this year would require us to deprioritise an investment that we've already taken through our planning process this year. So we've got some further work to do with colleagues to look at what the options are available there. And again, I'd like to invite Levi to say a few words there, Chair. So perhaps, Chair, if I go to Kelly first to just pick up the summary of where we are around agency spend reduction, and then Levi to cover BCF and mental health support teams in schools.
Kelly Angus, Chief People Officer.
Thank you, Chair. Just to give an update to board colleagues, we are collectively working very closely with our provider collaborative and our foundation trust and provider colleagues to ensure that we have very strong oversight of bank and agency usage across North East and North Cumbria. We use data which comes from the provider workforce return. It also comes from the finance provider return, but we also collectively look at local intelligence, local trends and local patterns across the whole area. And this area is, temporary staffing as a whole, is scrutinised through our Workforce Programme Board, which is chaired by Trudy Davis, who's the Chief Executive of Gateshead Trust, and she is the SRO for the Workforce Programme across the collaborative. We also take information to our System Recovery Board and also to our Provider Leadership Board. It is a very strong focus, and throughout 24-25 we have been monitoring our bank and agency usage collectively, and it was across North East and North Cumbria at the end of March slightly above where we had wanted it to be in terms of plan, 6.7%. However, our overall expenditure was reduced significantly, just about 33.5 million in terms of reduction in expenditure for 24-25, so a significant achievement, but we recognise that we have further to go, and the letter that we received from the Secretary of State and Sir James Mackey also outlines that. In line with the planning guidance, all organisations have been scrutinising the requirements for agency and temporary staffing. We have put in ambitious plans across North East and North Cumbria for 25 and 26. And we are proposing to take a reduction in bank usage of 23.3% and reduce our overall agency usage with a very ambitious target of 51.8%. Those numbers range quite significantly from quite a low percentage in some organisations to a very high percentage in other organisations. But actually, as a collaborative approach across North East and North Cumbria, we recognise that we need to go further. So it's not just agency staffing, but we have a planned collaborative bank approach which is being developed alongside NHS professionals. Some of that will be fully managed or a hybrid version dependent on what would suit the provider, but this work is progressing incredibly well and we have some viable options. We're now looking to complete that work and implement the bank across North East and North Cumbria. That work will also continue to help us retain and develop our staff as we move forward, but also help us adhere to setting pay rates, particularly across medical, which is a challenge for all organisations. I think I will leave it there, Chair. If anybody has any questions, I'm happy to answer them.
Okay. We'll perhaps take questions at the end, but Levi Buckley, Chief Delivery Officer, we've got some comments to make now.
Yeah, thank you. Firstly, in respect of the Better Care Fund, Board has previously received the updates on the programme for 25-26. There are a number of changes, particularly around the discharge allocation within the Better Care Funds. And as our Chief said, we co-produced these with our local authority colleagues, Foundation Trust and VCSE partners. There's a statutory requirement to them to be signed off through health and wellbeing boards, as well as the Integrated Care Board. Helpfully, just this week, as Sam mentioned, we started to receive the approval letters as an NHS England assessment process of all Better Care Fund submissions. We normally don't receive those until the end of June, July. So it's helpful to say that they've supported our plans. And the next phase for us then is to sign off the Section 75 agreements with our local authorities, which allows the formal transfer of funding. There are a whole suite of metrics that are specified nationally that all of our local authorities and our local delivery teams monitor. And there's typically a time lag due to the way the data flows. So we would expect the Q1 metrics to be available at the back end of July. So during August, we'll be doing our first assessment of has the schemes that we've invested in done what you would have expected, because there's always opportunities to refine the Better Care Fund proposals in year. So, Chair, we'll probably bring an update, excuse me, through August or September on those outcomes. Secondly, in respect of the mental health support teams, excuse me, as Sam says, this is a nationally mandated programme based on some trailblazers that were undertaken back in 2018 to 2022. The North East had a number of those pilot sites. The pilot phase concluded in 2022 with a national evaluation which recommended, wide rollout across the country. The planning guidance for 25-26, and we'll be referring again to our operational plan later, did not include any requirements around further expansion of the mental health support teams. We already have 35 within the North East and North Cumbria. We spend around £13 million delivering those, and we did have an internal plan trajectory to aim for 62 teams by the end of 2029-2030. However, as Sam said, we got a letter the back end of April from NHS England noting, although it wasn't in the guidance, would we, for all integrated care boards, come up with a plan to deliver further waves of the support teams during 25-26 and beyond. We've done some initial work and a response to NHS England indicating we believe we can create a further 5 teams in year. This will be during the Q4 of 25-26. We'll build on the additional 1.7 million investment we'd already planned for this year, but the work we'll have to do over the next few weeks will include reprofiling our financial plan, as well as some of the planned investments for mental health for the year ahead. I believe we will be able to achieve that Q4 in aim for this year, but there is a few risks in there, particularly around evolving workforce models. It relies on universities commissioning sufficient capacity, so we'll need to do some further work there. And we've indicated with NHS England we'd welcome some conversations about flexibility on fidelity to the model. The evaluations that have taken place suggest that there could be a different range of professionals that can achieve the outputs of the team, so we will continue to explore that. And I think just to reinforce, as Sam said, the concern here is if we see further requests in year to make additional investments or changes to our plan, which has been a challenging exercise, and given the current financial climate, it could put some further risk in for us over the year. So we'll continue to work internally over the next few weeks and with NHS England on the assurance against that ask.
Thank you. Anything else from you, Sam? So we've got a very comprehensive report from the Chief Executive and 2 specific aspects of it developed in a little bit more depth. Any questions or comments? Neil.
I'd just
Brian, Chief Medical Officer.
Thanks, Liam. I'd just like to draw your attention to one area in the report on clinical portals. This has been quite a controversial area within the ICB. They're effectively online platforms that house national and local guidelines. There's quite a variation across our patch and in which system is used and the accessibility of them. Just want to draw board's attention that we have done a full review. We've engaged with many stakeholders over a number of months, and we are recommending that the executive made the decision to recommend to go to a single platform across the ICB area. That will be easier to manage, have a more robust governance process, and save money in the long run. So it was just really to raise the awareness of this issue with the board.
Thank you very much. Sarah Malik.
Thank you, Sam, for your report, and Levi as well. Levi, I just had a question with regards to the mental health investment in school schemes. Obviously, I know that we have an increased ask. I guess what I'm asking for is some reassurance that the schemes are actually achieving the objectives and outcomes, that we are improving population health before expansion. So if you could share any insights, that'd be useful.
Yeah, thank you. As I mentioned, there was an evaluation done nationally by it was Birmingham Health School at the university there, which identified from the trailblazers their effectiveness and inform the future model. What the evaluations tell us is the teams work well for children and young people, so I should have mentioned these also work into further education colleges for mild to moderate. However, there can still be sometimes a gap between moderate to the more severe needs that would be an appropriate referral to specialised children and adolescent mental health services. The mental health support teams, there's a specified set of metrics, and that's both clinical outcomes but also experiential outcomes, including self-rated outcomes from the service users, and those flow into the mental health minimum data set. So part of our conversations with NHS England, we don't always see the full flows back out, so we've asked some questions around the data that comes out both from our teams within the North East and North Cumbria, but also nationally, so we can do some benchmarking. And we're going to undertake a piece of work with the 50 teams in the North East to do a bit more of a qualitative assessment on that, which will inform our plans ahead. So in a nutshell, yes, there is data collected, we do evaluate it, but I think there's probably a bit more work we can do to demonstrate the effectiveness and inform the future models.
Thank you. Rajesh Nadkarni.
Thanks, Sam, Kelly and Levi. Just expanding on what Sarah asked just now about the mental health teams in schools. I think the evidence is that that's great, absolutely, the impact they're making. What might be useful, though, is even if it's within the mild to moderate sort of areas of difficulties, if we can also try to get some support specifically for neurodevelopmental disorders, and especially I'm talking about conditions, I mean especially attention deficit hyperactivity disorder. And it might be useful that within our current data which is coming through, we also ask about how integrated they are just with the local authorities and the local VCSCs and the mental health providers to deal with that particular issue, which I think has been on the back burner, but probably needs a little bit more support and how should I put it, some support to actually escalate it a bit further.
Levi, do you want to come in on that?
Yeah, if I could just briefly respond to that point, Rajesh. We've had apologies from John Pearce, our Director of Children's Services for Durham, for the board meeting today, but John and I met last week. Again, I previously reported to board, we've got some pilot work in North Cumbria around investment for neurodevelopmental disorders, and now I think 3 pilots in Durham County. We had a very similar conversation, Rajesh, and felt that through the Directors of Children's Services Network, which I attend, we're going to bring back some of the outputs of both the neurodevelopmental pilots with the mental health support teams, just to do, as you say, I think there's probably opportunities to link those up better to provide a more comprehensive service. So, and we'll include provider colleagues in those discussions.
Thank you very much. Tom Hall.
Yeah, thanks everyone. My question related to the clinical portals, because I know there's been a lot of interest in primary care and secondary care clinicians around the particular platform that was to be taken forward. Do we have any more information on which platform it will be, or whether that's due to go out to procurement?
Neil?
So the exec are considering the options around that. We'll have to look at the value for money because there's quite a difference in cost of the 2 platforms, but that decision will be taken by exec based on value for money.
Okay. Are there any other comments or questions on this item? Thank you. Right. We move on now to the next item, which is a very substantive and important item. I'd like to make some introductory remarks and then handing over to the team who've been managing this process. Normally, on a subject like this, we would be considering a report with recommendations to adopt. Because this item relates to the major reorganisation that the NHS is undertaking, which does involve some reports going, including one on the agenda today, we want to give a work in progress report and be able to allow some discussion of the proposals and the work that's underway. As you know, around the table anyway, the Integrated Care Board concept was enshrined in the Health and Social Care Act of 2022, and we've been running under the terms of that act since the 1st of July 2022. The announcements that the government's made about changes to the way that the NHS is going to be organised and function have implications across many different parts of the NHS, but particularly for today's discussion for us, they will affect our staffing level, our staffing structure, our operating budget, our functions, our ways of working, and our accountability when they're implemented in full. So some of the implementation is already being framed, particularly relating to staffing level, staffing structure, and operating budget. But you'll see in the title of this agenda item the use of the term strategic commissioning organisation, which is really the best description from the proposals or the decisions so far coming from the government about how our role will be reshaped by these changes. And so we're going to be discussing today the staffing and budgetary changes, but we're also going to be discussing a report that is being prepared for submission to the government, which is actually to do with the way in which the changes have been put together, and what's being proposed by the government for the future. And before handing over to Jacqueline Myers, who is going to take us through this with her colleagues, I just wanted to finally mention that the process of change involves the integrated care boards like ourselves across the country, but there are other changes also happening which have a bearing on how we will be working in the future and to a certain extent how our functions will be delivered. First of all, as you're all aware around the table, NHS England as a statutory entity is being abolished and being, in addition to reduction of its size, is being absorbed into the Central Civil Service Department of Health and Social Care. So in future, the Department of Health and Social Care will be the headquarters of the NHS in England, and also the regional officers which we deal with day to day, who were the regional officers of NHS England, will become regional officers of the Department of Health and Social Care. We don't know whether their present number will stay the same or they will be reduced in number. That's something we're awaiting information on. Secondly, the NHS 10-year plan, which is currently nearing finalisation, has been widely consulted on, but mentions the three key shifts: hospital to community, treatment to prevention, analogue to digital, which will drive a lot of the agenda of the NHS in the next 10 years. But we're expecting that the NHS plan document itself will contain further details of structure and functioning of the NHS, including our own role. So that plan is expected sometime towards the end of this month, and we'll be watching that with great interest to see what we need to do in response. And then finally to mention that there is legislation pending on the role of the combined authorities, and we have a very close relationship already with the combined authorities in the North East and North Cumbria. But at this stage, it isn't clear whether they will be given any new roles in relation to health or health services. So that will be another important area of information to digest whenever it comes out. And then finally, just to note that the legislation that set us up was primary legislation. So we have statutory roles in so-called duties in the specified in the Act, which relate to something like 12 or 13 functions, including ensuring patient choice, reducing health inequalities, and assuring quality and safety of care. So all of those functions are extant as far as the statutory position is concerned, and we would expect the process of reshaping our role some of it will involve legislation, although some of it doesn't need legislation. But we're very, very, internally anyway, amongst myself and the team, very positive about the opportunity that becoming a strategic commissioning organisation involves, although some difficult and complex changes to work through. So that's just some introductory comments from me to set some of the context, but I'll pass over now to Jacqueline to introduce this item 9, which is in two parts. First of all, dealing with the financial and operational plan, and secondly, dealing with the proposals that have come in a document from the government called the Model Integrated Care Board.
Thank you, Chairman. So I'll start with the paper which presents to the board the final version of our 2025-26 plans. And these plans cover a full suite of financial performance standard activity and workforce plans, together with some assurance checks on the process. It's quite a long and complicated paper. I'm going to shortly pass to my colleague David to take us through the financial plans. I'll comment on the activity and performance plans. My colleague Kelly will take us through the workforce plans, and then I'll round up with the assurance checks on the process and the recommendations to the board, if that's okay, Chairman. So I'll just pass over to David to take us through the headlines from the finance plans.
Thanks, Jacqueline. So, Chair, it's okay, I'll take a few minutes to go through the financial plan for the year, given the challenging nature of it. I think it's just really important I take people through the key elements. So the main purpose of this part of the report is to seek final approval or ratification of the plan on the ICB and ICS side of things, but also to approve the contracts and similar that are over £13 million that are enlisted in Appendix 1 for completeness. So first of all, just want to be really clear with the board that the delivery of a balanced financial position on revenue across the ICS, which is the ICB and the Foundation Trust combined, is very challenging, and we have £244 million of unmitigated risk within the plan this year. And to put that into context, last year it was £160 million. So a significant increase. That's mainly driven by the fact that as a system we need to deliver efficiencies of an unprecedented level of around 7%. Last year it was around 5%, and obviously that brings with it considerable risk. In terms of the financial plan, I'd ask the board to note the following key items of context. So our ICB allocation is just over 8 billion, and then Foundation Trust bring in approximately an extra 2 billion. So the total, if you like, income or resources available to our patch approximate to around 10 billion. And whilst the ICB has the largest allocation per head, the third largest allocation per head of population in England, it is deemed by NHS England formula to be overfunded, like many in the north. And as Sam mentioned earlier, the last 2 years we've had the lowest allocation growth of any system in the country. And again, this year we've received 3.85% growth compared to an average of 4.1%. That's, in monetary terms, £30 million less. And when you've got that year on year, it does make a significant impact. And to give a little bit more context, what needs to come from that 3.85% increase? We have to budget for a pay rise of 2.8%, employers' national insurance of 2%, drugs costs increased by 5% on average each year, And care packages, individual care packages, costs and volume increase between 8 and 10% every year. And that is some of the reasons why the strain on the NHS resources in the North East are so acute. Some other parts of context to be aware of. Deficit support funding has been shared by NHS England this year of £2 billion. Most systems receive a share of that, not all, but most. And disappointingly, North East North Cumbria was one of the few where the figure for this financial year has been reduced by £17 million down to £33 million. There's also been reductions in transformation funding, commonly called SDF funding. We've seen, for example, a 25% reduction in cancer funding, and other areas where we've been told initiatives that we traditionally funded from transformation have now come from core funding. On elective recovery funding, last year we had an ability to increase income based on how much activity we're doing through the year. For this financial year, we've received a fixed amount of funding for elective activity, which is 2% less than outturn on last year, which equates to £18 million. And that's despite an ambition to further reduce waiting times. And lastly, we have historically relied on non-recurrent measures, as Sam mentioned, to deliver a financial plan each year. But there's, of course, only so many times you can do that. So, for example, there are only so many times you can sell land to help balance the books of the system or organisations as part of that. But despite those challenges, NHS England and the Secretary of State for Health have been very clear that all ICSs must live within their means, must maximise productivity opportunities, and must make necessary but sensible decisions, difficult decisions to live within their means. And they've been very, very clear on that matter with us. So within the plan, you'll see 3 plans. Also within the paper, you'll see 3 plans. An ICB revenue plan, an ICS revenue plan, and an ICS capital plan. I'll just go briefly through the ICS revenue plan because I think that's the most important one. And again, that's the ICB and Foundation Trust combined. You'll note in the report that we initially submitted a plan in February with a £180 million deficit in it. And that included an average 5% efficiency saving. And that's commiserate with the level of efficiency that was delivered last financial year. Still high. But that, at a national level, that led to a £4 billion deficit, which was not acceptable to the Department of Health or NHS England. And since that date, we've been working to pull together a balanced financial plan. So all foundation trusts within the ICS have now produced and had approved plans that are in line with last year's control total. And that was a target that we set every organisation in the system. 2 exceptions. CNTW are improving on last year's plan by £3 million, whereas Gateshead Health have been unable to achieve last year's control total. Their plan is approximately £11 million worse than last year, but that has been agreed across the system and with NHS England. Now, rather than submit a deficit plan of £8 million, we have as an ICS agreed to cover that risk and submit a break-even plan. Put that in context, £8 million is less than 1/10% of our allocation, and we believe that is a manageable level of risk to take in for submitting a balanced plan. But as I say, it requires average efficiency levels of 7%. Within FT plans, that includes £200 million of what we might call difficult decisions, and it assumes workforce reductions of around 3%. To put that in context, last year reduction was effectively flat in workforce, so we're looking to see a reduction in workforce across the ICS. On the ICB revenue plan, we've got a surplus plan of £12 million, which helps offset that risk in Gateshead and across the provider sector. Our plan includes £126 million of efficiency savings, of which £30 million are ICB-led difficult decisions. That includes reductions in local delivery team place budgets of around 6%. That was following a line-by-line review of every individual budget, which is following the expectations from NHS England. And we've also saved £15 million on transformation budgets. That's generally things where we had a budget for something, but we're not going to take it forward, rather than stopping something that actually currently exists. All our cost improvements will be subject to quality impact assessments, and they will come to future board meetings. On productivity, NHS England provided a suite of information to every foundation trust and every ICB about where they felt the opportunities were for organisations to improve. The one that really stood out for our ICB was that NHS England believed we spend £18 million too much on individual package of care compared to benchmarks. And whilst we might challenge that number, we have set the savings target in CHC at £30 million, which is approximately double the value that we'd normally allocate to packages of care. I do want to iterate some of the good news items that are in this year's plan. So first of all, we have set aside, as Sam was alluding to, £5 million to support the implementation of the forthcoming NHS 10-year plan. You know, to support things such as treatment to prevention or acute to community. £5 million was set aside, and we'll be able to use that this year to support ARI hubs continuing and to ensure that we've got robust and consistent spirometry services across the patch this financial year as well. And that is something we'll look to do every single financial year in order to support that left shift that is talked about. Also, the Mental Health Investment Standard. We will achieve the Mental Health Investment Standard in 25-26. For those who aren't quite remembering what that standard is about, it's basically ensuring that more money is going to mental health than the average that goes into all other services that we commission. And lastly, in Middlesbrough, which is one of our most deprived places, we've committed and we've allocated an additional £2.6 million to Middlesbrough Place, which is part of a 4-year programme to increase the level of funding based on the formula that we have that suggests Middlesbrough is the one patch maybe that is below target allocation in our patch. ICB running costs, you'll see in the plan that we commit to the second year of the 30% reduction that was given to the ICB by NHS England last year. And as mentioned by Sir Liam, we now have additional running cost and programme cost savings that we need to make during 25-26, which will need to be in place for the end of Q3 of this financial year, and we'll no doubt come on to that later. On capital, there was a reduction in our ICS capital funding due to formula change again. That has been offset by funding for estate safety and constitutional standards. We've effectively been led into a much more complicated capital regime this financial year. The Provider Collaborative have led on that, and I'm pleased to say that we have a balanced plan that has been put forward for approval. My last point, though, would be about financial risk. And just to reiterate what I said at the start, financial risk of £244 million. It's the largest that we've ever had as a system. The level of efficiencies of an average 7%, and that's an average, remember, some are higher than that, are at unprecedented levels. And this year will be a very challenging year with less, if you like, headroom and scope for managing things where we go awry as a system in this financial year. So, as I say, a very challenging plan, but one that's been submitted to NHS and been accepted and is here for final approval. Thank you, Chair. Oh, sorry, I'm back to Jacqueline, sorry.
Thanks, David. So just to build on that, as we move through the paper, I will make some brief remarks, Chair, in relation to performance. However, it is a bit more straightforward in that I'm pleased to report to the board that the paper shows that at system level, the ICB and wider system is able to submit a plan that meets all of the asks of the operating plan guidance in relation to performance. Within the detail in the plan, it sets out under each of those headline measures where in one or two cases there are individual providers who were not able to submit a plan for their individual organisation that met the national ask. I'm just going to draw out a couple of those. In relation to the 62-day cancer performance, we have two organisations who are not able to meet the 75% ask. However, both organisations do have a significant improvement plan compared to their outturn at the end of this year. And then we also have one organisation who's not meeting the ask in terms of first outpatient appointment, that's Northumbria. And in that case, it's because they're already the best performer and have a very high level of performance against the standard. So they're posting a 3% rather than a 5% improvement. And then finally, we have a couple of organisations who are not meeting the requirement to get to no more than 5% of patients who are having a diagnostic test to wait more than 6 weeks. So some small exceptions, but in all cases, not a standstill, but an improvement and movement towards national standard, and therefore I'm pleased to recommend that performance plan to the board. And then just in relation to activity plans, to note that the 8 trusts who undertake elective activity were required to put a plan in place in relation to the activity they would do alongside the performance standard, and we've received an activity plan from each of those trusts, and they're contained within the plan also. So now I'll just hand to Kelly to make some comments on the workforce plan. Thanks.
Thank you, Jacqueline. In terms of the workforce planning round for 25-26, North East and North Cumbria entered into this round in a very strong position, considering the work that had been undertaken during 24 and 25, which would be predominantly been focused by the system recovery programme and the infrastructure and governance which had been developed to support that. So we already entered 25-26 preparation with a robust strategic workforce programme, and that very much focused around peer challenge, spreading good practice, reducing duplication, but also looking at where we could do things collectively better together. In terms of the workforce programme that had been developed already, we had already focused on 13 initiatives, and those initiatives were spanning a number of themes that would lead us into a workforce planning, strategic workforce planning round for 25-26, which would focus on some of the key challenges that we face as a system as well as across providers, and that included how we would improve productivity amongst our workforce. And some of those programmes are very much around job planning, around some of the e-rostering and some of the items that I've already talked about in terms of temporary staffing. But one of the things that we have absolutely honed in on is during 24-25 is the data, and that has put us into a strong position as part of preparing for the planning round for 25-26. We very much focused around grip and control. Workforce data fluctuates very quickly from one month to the next, dependent on demand, and we've been working very closely with our Chief People Officers and our Chief Financial Officers to really get underneath some of the data across the board for 24-25 to ensure that our plans for 25-26, whilst they remain challenging, that we have a very strong focus on delivery. We've very much focused around some of the well-being of the workforce. We've also had People Promise exemplar sites, which have been sponsored by NHS England. We've achieved some fantastic results around retention and staff experience. So we're looking to build on those and what those mean, how we use our workforce in terms of their productivity, but also very much around well-being. We recognise we employ a lot of people in the public sector across North East and North Cumbria, and we have also been focusing on the health and well-being of not only just our substantive workforce but our temporary workforce as well. We've also been linking with the opportunities that have been presented by the Health and Growth Accelerator around how we develop our wellbeing hub. That wellbeing hub is currently hosted by one of our mental health trusts, Cumbria, Northumberland, Tyne and Wear, and that's really how we support mental health and well-being for our workforce, which is something quite different to what we've done previously, and we're really quite excited about what that will bring for the future. In terms of that grip and control, we have also made ambitious plans as part of our submission that we aim to reduce sickness absence for up to 1% for most providers. Not all, but most have relished that challenge, but it is a significant challenge. 1% is considerable. And we are also, the workforce plan submissions that we have made do, as David Chandler had suggested there, also have reductions. And those reductions range from 1.8% to 5.7% across providers. North East Ambulance Service has not got those reductions. It also has a 3-year investment and growth programme to increase its workforce, but also some of those reductions. Reducing your workforce is challenging. We are looking at turnover and also natural means, but also voluntary mechanisms wherever possible. We have also, as I covered earlier, got reductions around temporary staffing within our plan submissions, and the majority of our providers have put together ambitious plans for those reductions. That will be challenging. A number of our providers are also suggesting that they have limited changes around their turnover rates, and some of that we have planned into our submissions in a very factual way, but we recognise that some of that may change based on some of the challenges that we have. The workforce across primary care is planned to remain in line with the previous year, reflecting no growth or reductions, but in terms of the risks of delivery, as David Chandler has already outlined, our final submissions that have been made are ambitious and challenging. This is a key topic and focus of our boards and also of our chief people officers and our chief financial officers. We are monitoring our achievements very closely from through our workforce programme board, but also each provider has a very tight grip of these issues locally. Thank you.
Thanks, Kelly. So I'll just move on then to Part D, which is the Board Assurance Framework. This is a new facet of the National Planning suite of submissions, but as an ICB we're in a strong position to respond to this as we have robust arrangements in place, both for the development of any new investments but also to identify and agree any contract changes, any efficiencies or any services we plan to decommission in order to make best use of our allocation. So those processes all have multi-professional, including clinical involvement and led by our Chief Medical Officer. And then, as you would expect, when we get to the point where we've got proposals, we have a clear equality and quality impact assessment process, which is led by our quality team under the direction of our Chief Nurse. You'll see on page 51 of the document there's an assurance checklist, and we are assessing ourselves as compliant with all elements of the checklist, except in respect to those equality and quality impact assessments where we're showing as partial. Now, the reason for that is we're tracking the ongoing development of those assessments as we develop the full and detailed proposals throughout the year, and we deem it not appropriate to sign them all off before we have the full and detailed proposals. But we have a very clear tracking process under our System Recovery Board, and we are tracking well so that we are completing those assessments before any of the proposals are moving through to implementation, and therefore I believe we can assure the board that we've got appropriate arrangements in place in regard to that equality and quality impact assessment. So finally, I'd just like to move to the recommendations in the paper, if I may. So there are 4 recommendations.
Sorry to interrupt.
Go ahead,
Jacqueline. We have had a couple of questions from members of the public submitted about the plan. So if we could take those, and we can build those into the thinking if we need to.
Sure.
Claire.
I think Claire's going to comment on those.
Yeah, thank you, Chair. So question 1 is from Mr. Bailey from Unifar Commercial. He specifically requests information from the Integrated Care Board regarding optimising medicine's value and improving the adoption of and compliance with best value NHS supply chain frameworks in medicine and procurement. The specific question is, which NHS supply chain framework will the ICB be prioritising to show projected savings in to implement the planning guidance? We will follow that question up with a detailed response. It will go on our website. The response to the question is we follow national frameworks and processes, but anybody wishing further information regarding that specific question can find it on our website later this month.
And we've got an item in that area later on the agenda, so there's more information come through that. We have indeed.
And we've had a range of questions from Dr. Helen Groom from Keep Our NHS Public, NHS North East. Helen is in the audience. Welcome, Helen. Many of the questions are linked to the EQIA process and whether or not they will be processed, as well as some service change elements and whether or not the list of discretionary services and information regarding these services will be made public. I have spoke to Helen earlier and just confirmed that we will write in full again to her questions and also put them on the website. But just to confirm, any changes to services that are deemed as significant variation need to follow an appropriate process in line with the Health and Social Care Act, which is exactly why we have set up the Service Change Advisory Group, really to look at process as well.
As a result, it is inevitable that that information will be made public through the relevant routes, including the overview and scrutiny committees, and also working with our Health Watch as part of our engagement and, if necessary, consultation process. But again, we will answer those questions in full, Helen. Thank you.
Thank you. And then just before you get to recommend, just one thing to clarify with David. As you know, the organisational changes require foundation trusts to make staff reductions and reduce non-clinical services. There's been a less publicised aspect of the changes, but are those measures or proposed measures incorporated into your financial plan, or is it a separate exercise that's going to come later?
So the item you referred to there, Chair, is that all foundation trusts received a letter from NHS England, which in essence said that they were asked to reduce the level of corporate growth from pre-COVID days to now by 50%, and various information shared in terms of benchmark information in terms of that increase on a comply or explain basis. Now, most foundation trusts were already looking in that space anyway as part of being as efficient as possible anyway, and we know through doing the peer review exercises that we did them as part of the plan that that was certainly something they were looking at anyway, so these things were coming together. So within every foundation trust plan, there will be corporate efficiency savings built in, and they'll be sharing that information on a comply or explain basis with NHS England. So in short, I would expect every foundation trust to be looking at that, have that as part of their plan. It might not exactly balance to the numbers NHS England have, but that's because it's a comply or explain regime. I'm sure Ken from the Provider Collaborative might be able to add more to that, but that in simple terms is what's happening.
Does it have to be approved by NHS England as a separate activity or not?
I think there's an expectation NHS England will look to confirm that they are, if you like, happy with what's been presented to them. So that's justifiable. If they maybe aren't saving by 50%, they can explain why they're not doing that.
Sam?
Just to follow up, I think we'll be expected to declare compliance by Q3 and also make something explicit in our annual reports to that effect.
Thank you, Chair. Just one thing I want to add, not necessarily preempting the next item that Jacqueline's going to present on, but it is a financial risk related to our 25-26 plan, which is the transition to becoming a strategic commissioner requires us in the ICB to reduce our workforce, and inevitably one way of doing that would be through voluntary mechanisms such as redundancy. At the moment, we don't have confirmation that redundancy costs will be met, and therefore we're estimating our redundancy costs between somewhere in the region of 20 to 30 million pounds, and should we need to meet those costs within the ICB, it will obviously be a risk to delivery of some elements of this plan. So I think that really is just at this point in time for the board to note that risk, Chair, but I just wanted to share that.
And one thing we haven't covered, Sam, is just in general terms, as a result of these major financial pressures, is it likely that there will be proposals for service change?
And there could certainly be potential for service change if we have to meet that cost pressure within existing resource. I think the team has already set out how challenging and stretching the plans are this year, with a number of changes planned already to secure an additional 20 to 30 million pounds to meet the cost of NHS staff redundancies within existing budget would require us to go back to our investment proposals and commitments.
Thank you. So before Jacqueline goes through the recommendations, are there any points or questions any of the board members want to raise? Sarah Malik.
Thank you, Jacqueline, and thank you for everybody for their presentation. I guess it's just a slight challenge to us as a board, Sir Liam, that obviously we know that looking at the numbers, head in the North East North Cumbria ICB works out to approximately 3,125, just in broad measures, which is 50% less than most European countries spend on their average head per population. And I guess my question is that if we know that finance is driving some of our decisions, are we confident and reassured that the services won't have a significant impact on population health, considering the direction of travel that we're going as strategic commissioners? Are we confident and reassured that the population health won't be affected by the decisions that we're being asked to make?
Do you want to take that question, Sam?
I think it's a really good and important challenge, Syra, and I think particularly in terms of the risk around things like growth, and particularly given the level of health inequalities within our population, this inevitably is a challenge. I think the answer to your question will come through the equality impact assessments in terms of the proposals and the impact in terms of either a loss or change of service and the impact on population health. Having said that, equally, we also know that there are opportunities to use the resources we've got at the moment better to drive better value, and that inevitably is a consideration as well.
David Stout.
Yeah, very, very challenging agenda for the current year. Just very quickly, David, with regard to the ICB and the management reductions that Sam's been alluding to, our efficiency savings target in the ICB is £126 million, which is a sizable sum. Is there a risk, I suspect there probably is to some extent, that the management change that we're carrying out may impact upon delivery of that £126 million, and what are we doing to try to avoid it if we can mitigate it?
There absolutely is a risk of that, because any organisation going through such significant change, there is a danger of distraction, shall we say. Quite understandable in terms of people being concerned, will I have a job going forward, and will it be the same job I'm doing now? So that is a challenge. If I brought Sam in now, she would say, I'm sure, that we have agreed as an executive what our key priorities are for the next 6 months to ensure that absolute focus, team by team, and as an executive, about what is important. So to narrow down what we're actually focused on, making sure that we are targeted on those. And one of the top priorities was the delivery of the financial plan. Not the only one, you'd be pleased to know, but that was one of the main ones there, to ensure as an organisation, department by department, we focused on that one. We've also put additional measures in place, such as star reviews. We've got a financial sustainability group in place for the ICB, which reviews efficiencies once a month. So we've got a lot of work and processes and systems in place to try and prevent that as much as possible. With any plan, though, there's always a risk that you could go off plan. Part of my job is to identify contingencies should that happen. Okay.
Thank you. We have a break scheduled at 11:45, but we haven't finished item 9.2. So I propose we have the short break now, and then come back and deal with the next part of the agenda, item 9, which is the model ICB. So if we could, oh, I'm sorry, we've got to approve the recommendations first. Sorry, my mistake. Go ahead.
No, thank you, Chair. So there are 4 recommendations. The board's asked to approve the final ICB and wider integrated care system financial and operational plan submission, to note the requirement for robust equality and quality impact assessments to be carried out for the key efficiency and difficult decision schemes in line with our approved ICB policy, to approve the updated ICB revenue budgets for 2025-26, and these are scheduled out in Part A, Table 2 of the paper, and these include those contracts which are above £30 million and therefore are reserved to the board for approval, and then finally to approve the ICS capital plan, again as set out in the paper, in this case in Part A, Table 6. Thank you.
Is everybody content with those recommendations to approve them? Thank you very much indeed. So we'll break now and restart at 5 to 11. the Integrated Care Board for North East and North Cumbria. And coming now to item 9.2, which is the discussion of the proposals in the National Model Integrated Care Board report.
Thank you, Chair. I recognise that this is an item of interest, and it's quite a complicated and multifaceted one, and one that we want some time to have questions and conversation on. There are a set of slides that are up here and also were shared with the board in advance in the pack. So I think I'll whistle through the slides if that's okay, to leave some room for conversation. But just briefly, because this is the first public board meeting we've had since the ask in relation to the transition to strategic commissioning for ICBs was announced, I'll just briefly set the context. ICBs received a letter from NHS England on the 1st of April setting out a requirement for us to substantially reduce our running costs and also the costs that we spend on directly employing staff to run programmes in relation to services. The headline ask across the 42 ICBs in England is a 50% reduction in those costs. Subsequently, we've received a calculation that sets out a maximum spend per head of population that your ICB serves. That's £18.76, and for us within North East and North Cumbria, that translates to a need to reduce the cost in scope by 32%, which coincidentally, because we spend around just over 100 million on those costs, means that the saving in cash terms is just over 32 million, about 32.3 million pounds. And the ask is that these reductions in costs are achieved by the end of the calendar year. And then just the other bit of context is that in support of this, we've received something called the Model ICB, which is described as a draft blueprint for how ICBs should operate in the future, which essentially indicates a pivot to what's described as strategic commissioning. And within that document helpfully sets out some of the capabilities and functions within integrated care boards that should be developed and amplified, and others which in time can potentially be transferred to other parts of the NHS system, either to regional offices or indeed to providers. So we're using that document as a guide as we navigate this change. And lastly, just to say, as the board would expect, we've set up a formal programme and governance to support the development and delivery of the changes that the ICB will need to deliver to meet this ask, and those sit under the auspices of the newly formed transition committee that we discussed earlier that's been established. So I think we will discuss later when we note the terms of reference that's been established. Okay. So without going into lots of the sort of detail around the programme governance, what I thought we would do today is just see some early work on the thoughts about how we'll evolve our operating model as an ICB in order that we can start to engage with that. Just to say finally, in relation to the timelines, obviously that very ambitious timeline set nationally to get these changes implemented by the end of this calendar year in December has meant quite an intensive and rapid process has had to take place in terms of developing these proposals, because as colleagues around the board will know, changes of this scale will require significant changes to our staffing structure, and there are regulations relating to the need to formally consult staff around those changes, all of which take time, and working backwards from that implementation date at the end of December have meant that we have had to set an ambitious timetable to get out to consultation with our staff by the beginning of July. So there's lots of work going on, as Sam intimated in her board report, to rapidly evolve these proposals during the month of June and develop alongside them a draft proposed staffing structure. So just to kind of recognise all of that context, that we share these at a point in time in order for sort of transparency and opportunity to discuss them with the board. So I'll just whip through the slides, as I said, because they're in the publicly available board pack. But just to say, we've set some clear design principles. These were both informed by the literature and then iterated with our senior leadership team in order to have a clear set of design principles that would inform the way that we seek to work in the future. And I won't work through them all, but hopefully the board would recognise that they're all really useful and apposite principles for us to hold ourselves to account against. We then set out a design process using the design sprint methodology, and this slide just sets out the process that we're going through and as we're working through it. Within the pack, it also shares a bit of detail about just the breadth and depth of engagement that we've managed to already achieve in pursuance of a new operating model, starting with an all-staff conference with over 800 members of staff involved in an afternoon of design, and using some technology, then putting that into a session with 140 senior leaders over 2 days to iterate the first cut of our operating model. And we're continuing to work that through and test it, and I'm going to share with you some of the early outputs of that. Where we've got to at this stage is that we've developed an approach to how we'll operate the organisation, which encompasses 3 groups within the organisation, who will be led by multi-professional teams and will work together to arrange the services for our population. And so I'll move on slightly. One of the, if you like, foundations of this is to really think about how we embed multi-professional leadership in everything that we do. And we're defining multi-professional leadership as clinical, commissioning and finance. As I said, we've then looked to think about how we would organise our functions within the ICB, and we've chosen these 3 groupings. At the centre really is that commissioning group, where we're proposing to go for a much simpler operating model and organisational structure, where we bring together the multi-professional teams who will commission our services in sectoral groups, but also which will have the opportunity to operate on sort of geographical footprints and thematic footprints as needed. And they'll be supported by this insight, strategy and policy group, and really that's those functions that we feel are sufficiently specialist, technical, and, if you like, small in scale, that they need to sort of sit in one place in the organisation and then align to the strategic commissioning group. And then finally we'll have the corporate services group, which again will align around the commissioning group, but will include some specialist functions such as how we engage and involve with our public, how we deal with complaints, and crucially how we govern the organisation and run ourselves internally. Within the slide pack, and again to leave time for conversation, I won't go through all of this. We've started to elucidate what are the specific responsibilities and areas of focus for these 3 groups, and happy to engage on these and take some questions. And just to say, we're also very much engaging with our broader stakeholders as well. So we've had some really useful meetings with our local authority partners, with our NHS provider partners. We're engaging with our primary care collaborative, and also with our voluntary and community sector organisations, and that's ongoing. We've designed something called a workshop in a box, which we're going round talking to various stakeholder groups about, and there'll be further opportunities to engage as we go through the process. In the pack also, we've set out the risks that we've identified. Again, I don't propose to go through these, Chair, but just to say that we're very conscious that there are a number of risks, and the risks really fall into 2 categories. There are risks to delivering the project on time and meeting its objectives, and then, of course, crucially, there are broader risks to our ability to meet our statutory objectives and deliver our plans as an organisation, as we briefly discussed under the last item. So I mentioned the timeline earlier. This is just the sort of next steps. So just to say, we're working through the kind of more detailed exposition of the operating model and the associated staffing structure, with a review to bringing that back to the transition committee on the 24th of June. And prior to that, we're going to have a kind of development discussion with the board, so board members can have an opportunity to input into that process, with a view to bringing a paper proposing sign-off for consultation to the board meeting in early July. So that's a real whistle-stop tour. I hope that was reasonably cogent, and happy to take any questions. Thank you.
Thank you very much, Jacqueline. So questions and comments? I mean, some of you will have had the opportunity to discuss aspects of this, but are there things that you feel, from point of view of debating this in a public arena, that we should be flagging up? I mean, the risks are clear, the organisational shape is clearly explained, but are there any concerns or further questions anyone would like to raise? Sir Pally.
Thank you, Sir Liam. Just in relation to what you've just said, I'm delighted that the public is being consulted through this process, but I wondered what's the level of awareness amongst our population of these cuts? Do people know that these savings have been set out and that we're going to have to make them? I don't believe that most of my friends and neighbours are aware of what's happening.
Thanks, Pal. And Claire may want to comment on this. I mean, there has been quite a bit of press in relation to it. This is the first time we've had the opportunity to have a public discussion of it here at the board. So I suspect it's really mixed. I guess to some degree, some of it could be seen as sort of internal changes to the operations of the organisation, and therefore of less obvious public interest than changes to services which are directly provided to patients. But I don't think we're getting a lot of public inquiries directly to the ICB about it. But Claire may want to comment further.
Thank you, Claire.
Yeah, just to agree with Jacqueline, I think this is very much seen as a managerial change. I think the interest comes when we start talking about services, and aligned to the previous discussion that we had just before the break, Sir Pally. Notwithstanding that, however, there has been quite a lot of media interest in not just what we're doing, but nationally. I think it's certainly been recently covered in some of the local newspapers, but I just don't think it registers until people are talking about services and how it's going to impact on them.
I think the part that's sometimes neglected in public debate of changes like this is that there's no real acknowledgement that in order to develop services, not provide them, develop them, you need a fair amount of strategic movement and thinking and redesign. And especially if the emphasis is going to be on population health. And certainly my long experience of public health, population health, and trying to change things, there are relatively few examples across the country where there has been transformational changes in population health that haven't relied on technology, which obviously if you get a new drug or a new piece of equipment, a new piece of technology, then okay, you don't need the human intervention really. But if it's about building partnerships and getting people to work together and getting people to be less territorial and commit to a common cause, it's very, very hard work, and you can't just press a button and make it happen. And that's why, you know, I've always felt very passionate about this level of the service when I was in the Regional Health Authority, when I was Chief Medical Officer, looking without the regional directors of public health, I would not have been able to introduce a smoking ban. They prepared the ground, they got partners interested, they consulted the public and got people enthusiastic. So I think this is a serious business, getting this strategic layer with the right people doing the right things, and it's not something that should be regarded as a take it or leave it thing. Sorry about that outburst. David Stout.
That was fine. That's very interesting. You're to be congratulated. I think the design, sprint and engagement work is really impressive for a number of reasons. The ideas coming up and also engaging the staff, at least being two of them. But the question is this. Presumably the odds of getting this new structure right first time is probably remote-ish. Are you thinking about putting any sort of contingency in, or if not, because you can't, then further down the track, can you actually effect some change to move from where you're set up, because you thought it was a great idea, to something slightly different? You know, I'm just thinking, you know, the number of full-time equivalents in this area as opposed to another area, that's what I'm thinking about, really, the detail of it, really.
Thanks, David. I suppose a couple of comments in response to that. I guess we've had the dubious pleasure of reorganising the commissioning layer 3 times in 3 years, and so there is significant learning from the kind of previous work that we did. I think we've learned quite a lot of things about how to be effective at scale and balance that with localism over the last 3 years. So there's quite a lot of learning feeding in from when we were established as an ICB and when we made the changes as a result of the last running cost reduction, is what I would say. There's also a huge congruence in the feedback that we're getting from the staff about what needs to work differently and how we could operate more effectively even within the constraints of reduced resource, although people are very concerned about the scale of the reduction resource. And I suppose the second thing I'd say is that I guess we're thinking about agility, and we believe that with a more simple operating model with broader roles that take a kind of broader responsibility for the commissioning cycle, that gives us more flexibility for course correction down the line compared to a structure where we have much more specialist roles siloed into individual departments where there's potential for gaps or duplication to arise. So I don't know if it directly addresses your question, but certainly we've sort of learned enough to know you don't always get it right first time. And I think with that broadness of commissioning roles, that will give us a bit of agility to course correct if we haven't quite got the resources exactly right first time round.
That's a very good response. Thanks very much. Thank you.
Eileen Kaner.
Yeah, so again, thank you from me. That was a good presentation, and you know, we never thought we would be here trying to design a transition when we haven't got the ultimate plan, which is the 10-year plan. I'm going to ask a question that I asked in the transition committee in its first meeting, but here for the public board. The work you've done on engagement internally is extensive and to be commended, and you've had a lot of learning from the last time you had to undertake a major internal transformation. There are 42 ICBs in England. We don't think there'll be 42 at the end of this process, but you know, what is the process for engaging outside, looking at the solutions that other places are coming up with, so we can learn both internally and also from what some of our peers and other ICBs are doing?
Shall I take that? Thanks, Eileen. There are networks in place, both in our region. So we're meeting weekly with our 3 colleague ICBs in Yorkshire, and there's also a national network of those leading the changes. I think a reflection would be that because we are currently the largest ICB of the 42, we're in the fortunate position where looking at a potential merger or cluster with other ICBs is not a facet of our response to this change, because I think that brings a whole layer of additional complexity in terms of how you navigate it, and that's the situation a lot of our fellow ICBs do find themselves in. But we are engaging with our colleague ICBs in lots of ways, often on specific topics. What shall we do about, emergency planning, for example, was a conversation I was in yesterday. So there's lots of learning and sharing, but we're all trying to progress at pace. So sometimes that militates a bit against that very considered engagement, but we're certainly maintaining a very open channel in that regard.
So a final comment from Lisa Taylor, and then I'll ask Sam Allen, our Chief Executive, to make some concluding comments.
Thank you. I noted that, with reassurance that there's VCSE engagement built into the plans, and I know that we've communicated on behalf of the local infrastructure organisations and the VCSE partnership programme directly with Sam and Salim about the future of the work between us as partners. I was just wondering, what do you see as the VCSE's role at sort of strategic level and at delivery level within this new model?
Thanks, Lisa. So, as you've noted, we are making sure that we engage with all partners, including the VCSE, and we're just in the process of taking this so-called workshop in a box around all of our places, so there'll be some local engagement, as well as obviously the strategic engagement with partners such as yourself. I guess it's a big question. I'd expect that we will be thinking about how we engage with the VCSE throughout the operating model. Within that strategic commissioning group, we're really thinking about a focus on neighbourhood health as one of the themes that we cluster teams around. And I guess that would be where, principally, if you like, within our future operating model, we'll locate our engagement with the VCSE. And this more simple operating model, I think, will make real sort of clarity around kind of the locus for where we'll engage with you, I hope, in the future.
Thank you, Will. Thank you for the discussion. And I'll now ask Sam Allen to make some concluding comments, and we'll move on.
Thank you, Salim, and thank you, Jacqueline, both for your leadership and for that presentation as well. As Jacqueline has said, this is the third major reorganisation we've done in our 35-month tenure as an organisation. The first one was bringing together 8 clinical commissioning groups to create the ICB. Last year, the former Secretary of State for Health under the previous government mandated a 30% running cost cut for all ICBs. And as the paper sets out, this is, for some ICBs, over a 50% reduction, and for us, just over 30%. But significant, nearly £35 million, and we spend most of our money on people. So this is absolutely having a further impact on our staff who are going through the third major reorganisation. Having said that, I think what this really signals is the change that will come through the new 10-year plan. I think the recognition that Lord Darcy highlighted that the 42 ICBs are all working slightly differently, and therefore some clarity on their role and consistency in the application for that. It means change for us, it will mean change for our partners. We will not be able to work in ways in which we're operating at the moment. This will require us to work at scale and to commission services across our population. So I think, Chair, what this signals is the start of the reform that the NHS will need to go through and the part that everybody will need to play in that. And I think your question about to what degree is the public aware of the change that is coming? I think we've seen over 1 million people engage in Change NHS and the conversation on the new 10-year plan. And I think the new 10-year plan, when it is published, will signal a real step change in how we do things. Having said that, we have services that we need to run today. We have important relationships, and what I hope we can achieve through this is the best possible outcome for people who have committed, for some, a working life in service to the NHS, to be treated well through the change process, but equally that we can deliver improved outcomes for our population using the NHS resources. And I think the principles that we've set out, the learning that we've had through the 2 previous reorganisations certainly stands us in good stead, and will, over the days and weeks ahead, continue to learn from our other counterparts across the country as well in how they're approaching this, and continue to adapt what we do. We will bring the final proposals back to the board for approval on the 1st of July. It's a really critical month in terms of finalising our proposed structures. What I would say, and to your point, David, is I don't think we will get it right first time. We'll go through a 45-day formal consultation with our staff. We'll listen carefully to what they feedback to us, and I absolutely anticipate there'll be further changes as a result of that, and we'll obviously keep the dialogue going with our partners as well through all the engagement that we're doing.
Thank you very much. So we move on now to the item 10, which is the Board Assurance Framework, and Claire Riley, Chief Corporate Services Officer, going to present that for us.
Thank you, Chair. I am conscious of time. I am also conscious that this is a report that you receive on a regular basis, therefore should be very familiar with the content within it. There's just a few notable changes. Can I highlight some movements in risks? That's linked to the delivery of the financial position, and you've already heard today with regards to the challenges linked to that, and that's now reflected in the risk register and the BAF. GP collective action, which has decreased. Weight loss injections and right to choose, that risk has decreased also, and as has the pharmacy collective action. Therefore, there has been some slight movements there. There have been 2 new risks included now, which includes unplanned pharmacy closures and also the transitional programme, which we've just heard about. Closed risks include the in-housing of NECs and dental underspend. And there's been some changes to the EDI risk as well, which is detailed within the paper. So I'm assuming that people may or may not have some questions, Chairman, but what we ask is for people to just confirm that they're satisfied that the BAF reflects the principal risks of the Integrated Care Board in the system that we're managing within, to approve the BAF for Q4, please, and also to receive and review the Corporate Risk Register for assurance. Happy to answer any questions.
Thank you very much, Claire. Anything anyone wants to clarify on that? Are you happy then to approve the report? Thank you. Moving on then to the Executive Committee. This is the committees of the board which the minutes are put in the public domain, but there's certain things that we usually highlight. So we'll ask each of the chairs to do so. So Sam Allen on the Executive Committee.
Thank you, Chair. So the minutes include, the papers include the minutes of the 11th of March and the 8th of April, and you'll see reflected in the minutes our ongoing focus around delivery of our operating plan, and of course the focus on developing the strategic commissioning transition programme that we set out here. We also received the Health and Equalities annual report. We approved the use of artificial intelligence policy for the organisation, and we received our committee effectiveness review, which provided positive assurance on the business that we'd undertaken, and that being in line with good governance. Thank you, Chair.
Thank you very much. I want to note those three particular items, all very important ones. Any questions or comments? Moving on then to the Quality and Safety Committee, Sir Pally Hungings, the chair of that committee.
Thank you very much, Chair. The minutes are enclosed, and you can see a slide there which indicates the main points that I want to highlight today. Before I do that, I will point out that as we evolve and develop with the new way of doing things, I think some of the remit of our committee will change. In fact, the first item there, healthcare-associated infection rates, this may not be an area that we will specifically pick up in the future, but to report at the moment that rather disappointingly, our infection rates in our ICB locality continue to be over trajectory and somewhat higher than national rates. And a lot of work is being done at the moment to see why this should be the case. Although we don't have definitive data, the indicators are that this may be related to a slight lapse in hygiene practices at local level, and also estate factors in terms of drainage, the stress on wards, and the heavy usage in terms of wards. These are important things that can be looked at, and the structures involved in this are working hard to sort these out as quickly as possible. So that's the good news. With regard to maternity services, we noted in our committee that staffing levels remain fragile in many of our units, and that 4 of our providers are still requiring service improvement. But the good news is that they are progressing well in the appropriate direction. A further point that came us that concerned us at the last but one meeting was that there are shortages and delays in the availability of a range of medications from time to time. These are mostly outside our sphere of influence, and these are due to supply issues at national and international level. But these cause problems for our patients, many of whom need to shop around from one chemist to another to get their medication. I'm not quite sure what we can do about it, but we have discussed this with our pharmacy colleagues who are equally frustrated. And I think it would be helpful for us to point this out to our colleagues at national level to say that this is causing a disruption in our area, which is quite a wide one with, with a heavy rural presence as well. Finally, Martha's Rule, which people will be aware, is a system whereby parents or relatives of patients can ask for a further assistive facilitatory opinion on the situation of the patient. More than 140 units in our ICB locality are taking part in this. Early indications are that this is working quite well, and we hope to have the outcomes of this available by the time our next meeting is held later in July. So that's all I need to report. Thank you.
Thank you. I mean, some of these functions, some of these things are going to be affected by our new role. So obviously, we've taken a keen interest in, for example, the healthcare associated infection. I know a lot about this subject from my WHO responsibilities, and I have to say, obviously, I'm sympathetic to some of the pressures, but generally speaking, there's no good reason why we should be amongst the worst in the country. Absolutely none. And I look to chief executives particularly to do a stronger job on implementing what's a very straightforward set of implementation measures that are evidence-based, clear-cut, and there shouldn't be any room for doubt about what to do about the problem.
May I point out that there is a great deal of stress in terms of bed usage in nearly all our trusts. And that's one of the factors that's contributing to
it can be a factor, but even so,
yeah.
You can get it down to a level that's at least tolerable in the short term. Sam.
Thank you, Chair. I just wanted to pick up the point around our future roles. So in the model ICB, it is proposed that one of the areas that could be transferred to providers is infection prevention control. We do very little delivery of infection prevention control. In fact, most of that does sit with our providers already. I think as a strategic commissioner, we will continue to have a role to monitor quality outcomes in line with our contract. And I think one of the things we can also anticipate is some more radical transparency from the Department of Health and Social Care on the performance of each providers. And one of the things we may want to consider is, whilst we do have some information in our integrated performance report that we'll come on to, looking at what key set of metrics we publish to the population of the North East and North Cumbria on the performance of all of our providers and the outcomes that they are achieving.
Thank you very much. And then the Finance, Performance and Investment Committee. John Rush was the chairman of this committee, but Dr. Mike Smith is the vice chair, so he's going to present on this occasion.
Thank you, Sir Liam. The update on the screen is from the April meeting, so some of the points are now a little bit out of date as the May meeting didn't occur. So the key functions of the committee are to scrutinise and understand the finance and performance of the organisation. So we were presented on the finance and the performance. Most of the information this has now been superseded by the finance reports Dave's already presented, and that Jacqueline will present in the integrated performance report. So I'll not dig into that in too much detail. Levi presented on a deep dive into learning disability performance. We've been in each meeting doing a deep dive into one performance area. And if anyone's got any questions on that, I wasn't actually attending at this meeting, so Levi would be happy to answer questions on that matter. And then finally, there is in the board papers, there's a review of the committee effectiveness, which has been undertaken and shows good governance throughout the year.
Okay. Thank you very much, Mike. Any points or questions anyone like to raise there? No, thank you. Then on to the Audit Committee, Chair David Stout.
Thank you very much, Chairman. There's been 4 recent meetings of the Audit Committee. Minutes of the 9th of January are attached in the board papers. There have been 2 extraordinary meetings of the Audit Committee covering revisions to the scheme of reservation and delegation, and also the ongoing work on the annual report and accounts for the year that's just finished. Plus we had a separate meeting of the auditors panel to look at the possible extension of our external auditors by a further 2 years. The last normal meeting was then on the 10th of April, and we covered the sort of things that we cover at every meeting, really, which covers risk management, board assurance framework. We were happy with that. Self-assessment of the committee's effectiveness. We do that periodically to make certain that actually we are meeting the HFMA handbook's requirements around being effective. We also looked at the conflict of interest report. We look at cyber assurance work that's been going on, so we're happy with that. We have a national return that needs to be completed around cyber assurance annually, and we're in the middle of doing that at the present time. We review, very excitingly, the use of the ICB seal, which is very interesting reading. We don't use it very often, but we use it periodically. So that's the ICB seal. Then we have the normal finance update, internal audit update, counter fraud update, and external audit update. So we have lots of updates at the audit committee. In addition, in the pack, along with all the other committees of the board, there is the annual report for last year. So the audit committee annual report is set out in the standard format. I'll take any questions. Thank you.
Thank you very much, David. Any questions or comments anybody has? No? Thank you very much then for those reports. And moving on to item 12, which is Claire Riley, Chief Corporate Services Officer, terms of reference for the Service Change Advisory Group.
Thank you, Chair. We referred to this in an earlier meeting with regards to the importance of having oversight and around the process linked to any service change. You will be familiar with this terms of reference because it has previously come to this meeting for approval. The Service Change Advisory Group has subsequently met and have made some final amends to the terms of reference which you see in front of you now. I'm happy to answer any questions, but I'm hopeful that you will approve the terms of reference of this group.
Is everybody happy to approve the terms of reference? Thank you. Having been behind time, we're now ahead of schedule. So I would suggest that we take one of the items from the next section and then break at the planned time for lunch. The reason being that the people who are on the internet understand which times we're having for breaks, so it's better to stick to those if we can. Right, so we take the finance report then, David, if it's not too much of a surprise to you to have it sprung on you like that.
Oh, it's definitely a surprise, Chair. But I was hoping it would be a relatively short update as well. So you've got in front of you the month 12 financial report. Obviously, it's been a very challenging year that I've discussed many times in this forum. I'm pleased to say that subject to audit, both the ICB and the ICS will achieve its four main financial duties: the capital, the running costs, the revenue on ICB and the ICS on revenue. On capital, you'll see in the report we talk about an overspend, but that was an agreed overspend with region, so that was very acceptable. So I wouldn't really call that as an overspend at all, but in terms of technicalities, that's what we have to do. On the ICB side of things, I was just going to ask the committee to note that there were overspends of approximately £20 million each on prescribing and in CHC. And they're areas which we have efficiency plans for next year. And a lot of that was just down to either price increases or increased demand in those areas. But as I say, we do have SIP efficiency plans in both those spaces for next year, or for this year. And that makes sense. On the ICS side of things, you'll see that we talk about the recurrent efficiency. And there was a shortfall on recurrent efficiency delivery of £60 million, which is approximately 1% on the provider side. That obviously gets carried forward to next year. So when I talk about the 7% efficiency target for 25-26, part of that includes what wasn't delivered in the previous year. Some of that was down to timing and some of that was down to schemes not being achieved. A good chunk of it rested in one organisation. Quite a large acute organisation who have put additional measures in place to accelerate their SIP programme this year. And the last thing I was just going to mention was that we are doing 3 deep dive reviews with NHS England are leading on, which are happening at this moment in time. The first one was yesterday. And again, that's just to assure ourselves and NHS England that everything is being done that can be done to deliver as much efficiency as possible, as safely as possible. That's all, Chair.
Thank you. It's an excellent job done in very difficult circumstances. So thank you to you and your team, David. I know you've worked closely with the Foundation Trusts and other partners as well. So are there any questions or comments on the finance report? Thank you. Well, we're asked to do 2 things: to note the draft outturn financial position for 2024-25 and note the position on 25-26 financial plans, which are going to be presented separately, which we did earlier anyway. Yeah. Okay, so people happy with that? Thank you. Then still again a little short of the break, so taking another report that's framed as the timescale for between now and lunch, the digital inclusion strategy. Graham.
Thank you, Chairman. So colleagues will find in the pack the embedded draft digital inclusion strategy. I'll just get my notes in the style of DC, bear with me. So the digital inclusion strategy is in response to one of the unintended consequences of digital transformation. Colleagues will recall back in January of 2024 when our digital data and technology strategy was presented to the board and approved, there was a mention of some of the challenges that we face with digital transformation for people that are unable to access or unwilling to access digital systems and services. So the strategy that we've developed has been co-produced with a large number of our partners across the health and care system. It has been based on some of the principles laid out in September 23 by NHS England, which illustrate some best practice to include digital inclusion as part of our design principles for new systems and services. Colleagues will note that the style and format of the strategy is very similar to our digital data and technology strategy, and that's deliberate to try and keep the momentum and understanding for our population fairly close to things that they recognise. The strategy and its 5 key actions essentially include access to devices and data, the ease and accessibility of systems and services. It also focuses on skills and capabilities both within our staff groups but also our patients and population groups. There's also a key focus on the beliefs and trusts, and essentially that's the culture in which we adopt systems and services with a digital focus. And then last but by no means least, how we generate strong leadership and partnership arrangements, which is particularly important in integrated health and care systems. Our strategy also wants to consider an area that's relevant and important to our region, the broader health inequalities challenges that we face, and there's clearly an alignment between digital exclusion and some of the health inequalities that we face, and we've already heard about some of that earlier today. Clearly, as we start to develop the 3 shifts, and in particular analog to digital and some of the ambitions that will be laid out in the 10-year plan, we really want to consider those unintended consequences and where we can design services that have inclusion within that design process rather than an afterthought. Our strategic vision for digital inclusion is to ensure that all people, and that's patients, the public, our populations, have equitable access and clear understanding of the opportunities within those digital technologies. And that will then allow more accessible and efficient use of the health and care resources that we have. Our strategy is the product of widespread system engagement. In fact, I would say this has been a really engaging and co-producing piece of work that we've all had the benefit to work within. We've established very strong leadership. Indeed, our governance group that's chaired by one of our local authority executives has really led this particular agenda, and I would commend all colleagues for that particular work and the way that it's been co-produced, as I said. We've also laid out a fairly detailed roadmap of the delivery of some of our ambitions, and in conjunction with that roadmap, we're in the final stages of developing a checklist that will allow us to make sure that those design principles are part of the process of inclusion rather than afterthought. And alongside that, we intend to develop something that's similar to a compact, an agreement that will allow all partners to sign up and get behind this particular ambition. So, Chairman, I will be happy to take questions there. The report has been, or the strategy has been, to our executive committee with a recommendation for the board to consider and then approve if appropriate. Thank you.
Thank you, Graham. Are there any points or questions anyone would like to raise on this? It's been very thoroughly debated. I've heard discussions on it quite often during the last year. But Yeah, Lisa.
Thank you. I would just like to commend Graham and his team for the incredibly hard work that they've put into making this a really inclusive strategy. The work to engage partners from all sectors has been fantastic, and the end result will be a sort of a guide to how we can proceed with one of the 3 key shifts that we need to make in the next 10 years. So a big thank you to Graham and his team.
Well, thank you for the work, Graham. So we're now to break, let you retrieve your packed lunches from the car park or cold spots within the building, and we'll be back at 1:15. We're ready to resume meeting of the Integrated Care Board for North East and North Cumbria. And we'd reached item 13 on the agenda before we broke. And this is going to be the Integrated Delivery Report, and Chief Strategy Officer Jacqueline Myers is going to present it.
Thank you, Chairman. So you have before you the Integrated Delivery Report that covers the period of March 2025 for most metrics, with some metrics, including the finance ones, for February 2025. So it is some distance away now. So as I've done in previous boards, I'm going to take the report as read and accept any questions and provide the board with an update on the latest published data, which came out on the 15th of May. And there's a slide in the pack that covers that too. Just to draw out some key headlines from the report, the accident and emergency 4-hour performance fell back slightly in April compared to March, falling to 77.8% versus the 78.8% that we delivered in March. So slightly concerning. It did reflect quite an uptick in activity levels, particularly around the Easter period. I'm pleased to say that we did maintain very strong ambulance response times. And we are now seeing that performance improve as we go on through into May and June. And indeed, the percentage of patients in our inpatient beds in our hospitals who are awaiting discharge but need supporting by a package of care or a care home bed, so-called patients with no criteria to reside, is starting to fall now. It was 9.8 in the formal report in the board, but it's at 9.1% in these data published in March, which is the published in May, which is the April period. Very briefly, Chair, not a lot to draw out in terms of the planned care performance, but a strong and pleasing improving performance across all of the cancer and the elective, so the 18-week referral to treatment standards, as you can see there, although to note we still do have some patients with extremely long waits. You'll see here that as at March, we still had 153 patients who had waited over 65 weeks for treatment and were still live on the waiting list. These numbers have been coming down month on month across I think 9 months consecutively now, but obviously still a bit to go to get those very longest waiting times down. And although as we now move into 25-26, the focus is on all patients over a year, we will, as a board, still be keeping an eye on these very longest waits and reporting them regularly. And then just to draw out in terms of the mental health metrics, still needing to see an improvement on the impact of our talking therapies for anxiety and depression in terms of the easy for me to say, the reliable recovery rate and the reliable improvement rate. Just to say that as part of this year's plan, we have been given some additional funds to invest in talking therapies, and as we move to commission those additional levels of activity, we've got a weather eye on the efficacy of the providers that we're working with. So we're building into our process a look at the performance of the providers against these standards when we look to commission additional activity. And finally, it's just good to see that we have exceeded the national ask in terms of doing annual health checks on members of our population who have a learning disability. And these data, which are February in case of the dementia diagnosis, not quite yet at the ask of 70%, but getting there. And we do expect when we see next month's data that we'll achieve that target too. So just a very brief set of highlights there, Chairman, but happy to take any questions. Thanks.
Are there any questions or comments? I just wondered how you're getting on with the, because I read that you were starting to use the sort of quality control metrics, run charts and things like that. They're not reflected on here, but presumably they've informed some of the ups and downs and symbols in there.
Absolutely. So if you look at the appendices that come out with the fuller report that's published in the board pack, then where it's appropriate, we do use statistical process control charts to assess whether whether our performance against metrics is stable or unstable, whether it's improving, and if it is, or deteriorating, and if so, whether they're special cause or common cause variation. There are some targets where they have heavy seasonal variation where you can't apply those approaches, but in those cases we often look at year on year. So we did struggle with a kind of simple set of ways of displaying that more complicated set of assessments on this very summary chart, but suffice to say, in our sort of detailed assessment of all of the metrics, we do use those mechanisms.
So Palihangin.
I wondered if the ICB has had an interconnectivity role. In other words, if the waiting times are long with one provider and we have the overall helicopter view, we can say, why not transfer this patient to this other provider? And what's the situation going to be in the future? Or are the providers going to be siloed and will run their own individual waiting times?
Thanks, Pally. So in addition to us monitoring the elective waiting times at system level, we do keep a close eye on all 8 of our providers in the example of the elective waiting times. And we have an individual trajectory and month-on-month plan from each of those providers, and we monitor against monitor actual performance against their plans. All of them, as I reported in the annual plan paper, have this year submitted a plan that meets the national ask to deliver a further 5% improvement, so we'll be watching their performance against that. Just to say, in addition, the national NHS England team does some benchmarking for elective performance, and for trusts that are in the lowest quartile for performance, they have an intervention where they tier the providers into something called tier 2 if they're in the bottom quartile, and tier 1 if in the bottom decile, and then more frequent meetings, performance-related meetings, happen with the trust to agree what their kind of remedial plans are to improve their performance. And then lastly, just to say, in terms of your question about whether we move patients between providers, we do have a strategic elective programme that's led by the Provider Collaborative, but we're closely involved in that as commissioners. And within that, there is a so-called mutual aid work stream where they look at the relative waiting times by specialty, by provider, and for any and the longest waiters in any provider are contacted, and we explore whether or not they'd be willing and able to move to a provider with shorter waiting times. So that's a very active programme, and it has resulted in several hundred patients moving to a different provider than the one they were originally referred to.
Chair, therefore, I'm delighted to hear that, but in theory, therefore, everyone should have the same waiting time if we are transferring from one provider to another because of delays.
You've just said briefly, one interesting facet of the mutual aid programme is that less than half patients who are contacted and offered a shorter waiting time at another provider choose to move. So often patients will prefer to stay at their local hospital even if the wait's slightly longer. The other thing we are exploring is whether we can encourage our referrers to access waiting times and refer to places with shorter waiting times in the first place, because we know that one of the reasons patients don't want to move is because they sometimes have met the surgeon or the physician who's treating them, and they don't want to sort of change horses, as it were. So we're working on that, and as part of that, working with the providers to be more transparent about their live waiting times.
David Stout.
Thanks very much, Chairman. On GP practice, the number of indicators which are red, or certainly, well, they're all red, being the GP practice appointments within 2 weeks, the proportion of appointments same or next day, and the actual workload of appointments seen in month. And I know there is debate about the relevance of some of these statistics and the indicators, but I wonder whether you'd like to say anything about that, Jacqueline, or whether the figures are relevant, and if they are relevant, then is there any way of improving it over time?
I think they are relevant, albeit they only give us a partial picture, David. That's why we've maintained them in the IDR. I think to take a couple of them in turn, in terms of the overall activity levels, having dug into that a bit when we did a deep dive, I think we could be having a slightly more sophisticated approach to how we set that target, because as I understand it, it's set on the basis of previous years, and it can be quite sensitive to the number of working days, and so it's not perhaps set in quite the way, and the changes are fairly small from month to month. I think where it becomes useful is the sort of supporting reports underneath, where we can see the variation across our patch and identify areas for action within the overall figure. So perhaps it's quite high level in terms of what comes to the board, but I guess the board report is the pinnacle of a sort of pyramid of more detailed information underneath. I think we are seeing a bit of a trend in terms of that seen within 2 weeks. And again, I think if we had more time, we could debate about the efficacy of that particular measure, because there's obviously a balance to be struck between some of the kind of continuity of care things. There also seems to be a relationship and how quickly people are seen, but also there seems to be a relationship between when we benchmark, we do slightly more face-to-face appointments than average, but we have a slightly lower rate of being seen within 2 weeks, and there may be a bit of a trade-off there as the telephone appointments tend to be quicker to deliver.
Are there things that we can actually do to improve the position over time, do you think?
It's like Neil's poised to come in on that. I'll let him go first.
I think one question is what are we trying to measure in general practice? So there is something around, and it is quite a debate around, is the correct thing to measure just the number of appointments for access? And is that a good measure of quality? A lot of patients will tell us continuity is much more important than the actual number of appointments. So I think it's a very complex picture to understand whether or not these metrics are actually a good measure of a good quality general practice service. So can we do something to improve these figures? Yes, we could put more appointments in. Is that what is needed? Is quite a hot debate. So I think there's some more work to do on this. We've actually embarked on a number of GP listening exercises. We've done 2. We're doing our 3rd one later this week. And it's just going out and talking to lots of members of the general practice, mainly staff, so doctors, nurses and admin staff who work in general practice, to seek their views on what they would feel should be our priorities in improving that core offer of general practice. And it's really coming out with some interesting things. And one of the themes coming out is it's not just all about the number of appointments that you offer. It's often who are they with? Is the continuity there? All of those kind of things that are important.
Thanks very much, Chairman Selson.
Yes, Levi, please.
Sorry to prolong the discussion, but I'm just probably worth mentioning as well. So we do review all of this through the primary care subcommittee. We'll be bringing the next PCAR primary care improvement report. I think it's to the September meeting, David. And when we've been debating it there's still other factors. So, for example, the GP collective action that followed, we did see a capping around 25 contacts. Now, not all practices have stuck with that, but that will be a factor in there. I think, as Neil says, this also doesn't capture the whole range of different contacts. We've, through some of the listening exercises, but also some of the meetings we've been doing through the Commission Service Review, we also know, and it's frustrating, but our data quality is still not where it needs to be. So I do wonder, Chair, whether, although we've done an initial deep dive through FPIC, it might be something we can go explore further at the Primary Care Committee, and maybe it's worthy of a bit more detailed discussion here to give the board hopefully assurance against the work that we're doing there.
Thank you very much. Sarah Malik.
Thank you, Chair. Thank you, Jacqueline. A very comprehensive report as ever, with lots of detail and lots of percentages and figures. I'm going to ask you a question about numbers. You know I love my numbers. And I always ask you about the kind of overall commission services that we have and the service providers. So I just noticed when I compared our last year's figures to this year's figures that there were now 337 GP practices compared to 351, which I appreciate there have been mergers that we're aware of. But I also noted for the residential care homes, our numbers had gone from 781 to 711, and I just wondered if there was any insight that you held with regards to those change in numbers, particularly the residential care homes, because we obviously rely on our care homes to often provide short-term convalescence care for patients that are coming out of hospital, and obviously it makes a difference to the number of patients that are probably using virtual wards and requiring out-of-hospital first appointments, which I've noticed have also decreased as well. So if you could give me some insight into that, I'd appreciate it.
Thanks, Sarah. I don't know that I can give you a really detailed insight to that. I suspect we'll need to take it away and have a look at it. I mean, as you've defined in terms of the care homes, which is I think where you really focused, that the numbers have shifted quite significantly, and I believe it's mainly due to closures. Although there are some, some mergers and stuff, but mainly it's closures, and we know that that's a market that's under massive pressure in terms of provision, but I'd have to go away and get a little bit more detail underneath that to understand, where are there areas that are particularly impacted in relation to it. Your last point was about virtual ward, I think, and virtual ward usage is improving. We had a more ambitious improvement trajectory against which we haven't met, so it's red in terms of it hasn't met the plan we set ourselves, but it has improved month on month for about 6 or 7 months, other than it went even higher in January under massive pressure with a bit of special cause variation. So I think the trend for virtual ward usage is improving consistently over time, but not at the pace we hoped. But in terms of the kind of impact of the loss of care home capacity, unless any colleagues can comment on that now, I think we'll have to take that away and come back on with more of a understanding of it. Thanks.
Yeah, we'll support some of that work, Jacqueline. I think if you were to look at some of the Better Care Fund submissions, it also reflects what we commissioned. So we've had a greater focus on intermediate care and reablement capacity through our local authorities over the last year, which will shift the balance of those numbers. So there's probably a bit of nuance beneath that for us to explain. And just on the general practice, you're absolutely right, the 337 just reflects mergers or branches coming together. Yeah.
Mike Smith.
My question is related to the prevention elements in the report. So that there's more of them and more data on them than there has been previously, which is positive. And I do really like the inequality data being highlighted. But I wonder whether we need to be adding some month-by-month plans and try and get a bit tighter on these prevention goals, because these ultimately are the ones that lead to everything else going green. If we can prevent things, is that an option?
Yeah, thanks, Mike. I would mention at this point that we're doing a review of the integrated delivery report and thinking about how to improve it going forward, which you can already, I'm sure you're about to get a call about. But we're really going to sort of discern, what's the right frequency to bring metrics. And I think with some of the prevention ones, we put them in every month, but they don't actually shift every month. And so we're going to propose that they move into the twice yearly reports, subject to people feeling that's comfortable, and we get more of a deep dive into them. And I think it absolutely is appropriate to set improvement trajectories, albeit probably monthly ones are not practicable. But I think your broader point does stand. So I look forward to bringing something back to the board on that in due course.
Sam Allen.
Thank you, Chair. My question relates to CQC ratings. So we've got one general practice in Sunderland rated inadequate. So I don't know whether Levi could say any words about what we're doing with that particular practice, and Hillary may be the one residential care home in Gateshead that's rated inadequate. I mean, it is a good picture across residential care with, I think, 599 of the 711 rated good, but one rated inadequate there, and just thinking about the impact on residents.
So in respect of CQC involvement with general practice, it is slightly different from what we'd experienced with our foundation trust. So the first instance, the local delivery teams, primary care arm would always work with those providers and offer support. Bearing in mind, as independent contractors, the relationship is between the practice and the CQC rather than with the ICB. We would offer the usual range of support, including buddying arrangements with other practices. Depending on the degree of the CQC regulatory input, we would also then work with the nursing directorate through the quality team. So there's a kind of a first phase of local support, recognising that the independent contractors have to provide the assurance to the CQC. Second would be the level of escalation to our internal quality if we feel it needs further resolution. And then the third stage, which we haven't got into yet, is if the CQC regulations were not, improvement activity was not recognised by the CQC as being adequate, you might move into the formal escalation process, which ultimately may involve regulatory action being taken direct. I haven't seen that in the last 2 years. We do have some other practices, Sam, for example, in Cumbria, where we're providing some ongoing support as well. I don't know, if Hilary, if there's anything to add from the quality perspective.
I can certainly come in from a CQC point of view around the care home that was rated inadequate in Gateshead. We were very well aware of this care home. We've been working with the local authority and Gateshead Health Trust. We've had a lot of involvement. We are chairing the Senior Provider Concerns Group, and we've had really good engagement with the care home. It did initially close to admissions and took the rating very seriously. It has now reopened, but within that time they took the opportunity to look at what the risks were and look at how they can mitigate those risks. So they've had a lot of support and are certainly on an upward trajectory.
Okay, thank you very much. I don't see any other points anyone wants to raise, so we'll move on to the next item, which is the all-age continuing care, item 13.1, and Chief Nurse Hilary Lloyd is going to introduce this, and also Kate O'Brien, sitting at the end there, Director of Nursing, Mental Health, Learning Disability and Complex Care, is going to be involved in the presentation.
Thank you, Chair. I will hand over to Kate to do the presentation, particularly around the performance around all-age continuing care. But I guess I just wanted to take the opportunity to say, you know, all-age continuing care are really, they're a large group of staff. They're really dedicated teams. They've got amazing skills and knowledge and expertise in this area. And we have got an ongoing improvement methodology approach around all-age continuing care. We're reviewing all aspects of the service, and we've got a task force set up to do that. Kate's actually chaired that this morning, and within that we're looking at these performance outcomes. We're also looking at the impact on patients and their families, including learning from complaints and also the staff experience and the staff development, both working within those services and then ongoing needs. We will be looking at remodelling that service. We've had a lot of engagement involvement from all of our teams, including discovery interviews and an engagement day, so we can very much get their views on what a model service should look like going forward. We will be report that back in July. And just on that note, I'll then hand over to Kate to talk about performance.
Thank you very much, Hilary and Chair. So just for people's benefit, continuing care is a term that we use to describe the process where we determine whether or not an individual is eligible for NHS funding towards their package of costed care in the community. And this could be costed care in a care home, in their own home, or through a personal health budget where they have choice and control about how they commission their own care and support. Continuing care is inclusive of children and adults, and there are 4 broad definitions. So there's continuing health care, which is abbreviated to CHC, which people will be familiar with, and that covers adults and children. The Section 117 aftercare, which is aftercare that is funded following detention under certain sections of the Mental Health Act. There's personal health budgets, there's right to choose and right to request personal health budgets, and personal health budgets for wheelchairs, and also fast-track funding for people who are sadly rapidly deteriorating and approaching the end of life. The continuing healthcare process is governed by national frameworks for children and for adults, and it assesses an individual through 12 domains. It's a technically complicated process, and it often occurs at a very difficult and challenging time in a person's and their family's life, and keeping the person at the centre of the process and making sure that we're sensitive to the experiences that they will be having is absolutely vital, and is something that we are using to inform our model workforce going forward. What we know is that the processes are best applied and the outcomes best achieved where we work fully inclusively with the person, their family and partners and stakeholders like our local authorities and care providers. Similarly, as Hilary said, our continuing care staff have a wealth of experience and knowledge in this area, and we are making sure that we harness this in our all-age continuing care task force, which we have set up to engage, co-create, share best practice and inform the best arrangements for all-age continuing care in the new arrangements of the ICB. So I'm going to take you through 6 slides that relate to the performance indicators in the Integrated Delivery Report. I'm not sure who's going to... Is it me? Oh, it's me. So, this slide, each one of these bars represents an ICB in England. and this is raw data which is aggregated to 50,000 people per population. So what you will see on this slide is that there continues to be a high demand for continuing health care, and we are the third highest ICB in the country for receiving new referrals for continuing health care. Our completed assessment, so again, we've got a strong Q4 report performance here. So these are assessments that are completed within 12 weeks. Our benchmark is actually completed referrals within 28 days, and our performance does need to improve here. It is slowly improving, but we need to do more. Now, there are reasons why the assessment can't be completed in 28 days, and we are doing a deep dive into understanding what the reasons are why referrals aren't completed. Sometimes it's because the person isn't well enough to engage at the time that the assessment is submitted by partners. Sometimes it's their choice to delay, and sometimes we have to do some more thought around the capacity and how we include and involve the person in their assessment. But this is something that we'll be able to report on in a couple of weeks' time when we've completed our deep dive. This is the benchmarking of the number of assessments that take place in an acute setting, so in hospital. And so best practices is that you don't assess people in hospital because they won't be medically optimised, and you may either miss opportunities to consider eligibility, or you will assess needs that will improve once the person is back in their own home or back in the community. And as you can see, our performance remains strong in this area. There is a big difference nationally, and that is because other ICBs use the fast-track process rather than discharge to assess, to allow people to receive the care in the community that they need to enable them to be discharged from hospital. But we have a robust discharge to assess programme in the North East and North Cumbria. The fast-track conversion rate, so again, you can see that we've got slightly more to do to be in the better quartile here, but the vast majority of people who are referred for a fast track receive fast track funding, or they convert to having CHC funding. And then the number of people eligible for CHC, so as an ICB, nationally we benchmark third out of all ICBs for the number of people that we have who are eligible for CHC. Now, the benchmarking does suggest that we are quite far above the national average for converting assessments to CHC eligibility, and again that's something that we're looking at in more depth. So there's reasons for that, and one primarily is that people are eligible for CHC, and that links to our deprived population and a population that we know experiences more ill health. But it also might be about the timing of CHC assessments, whether we're doing them too early or too late in the process. So that is again something else that we're having a deep dive into as a directorate. That concludes my slides, Chair.
Okay, thank you. Anything you want to say to conclude, Hilary?
No, thank you, Chair. We're just happy to take questions.
Over to questions and comments. Sam.
Thank you very much. It's a complex area, certainly complex, I think, for the public to navigate at times as well. I just wondered, through the transformation programme that we've got in place, what some of the early indications are around the improvements or the opportunities for improvements that we can make across the system. I think the benchmark data was really helpful, the mixed picture there, and certainly some opportunities for improvement. But I suppose it's also the journey we've been on around the 8 former CCGs, consolidating processes, just where you see those biggest opportunities for improvement that members of our public, people needing to access CHC will feel, and also our staff working in the service as well, Kate and Hilary.
Thanks, Sam. So I think the areas for improvement that we've observed is around making sure that we have the right workforce, that we have the right capacity to be able to meet activity and people's needs when they're referred into our services. So at the moment, people can experience delay, and that delay happens at a time when people are naturally very anxious and have changing needs. We also have variation. So because we have become 8 CCGs that became one ICB, but we still have practices where we have variation how we approach continuing care, Section 117 aftercare and personal health budgets. And we could certainly do more to make sure that we are offering people the opportunity to have a personal health budget and have that choice and control over how their services are commissioned. I think thinking as strategic commissioners, we have opportunities to work with our local authorities to drive improvements in the quality of care that people experience in the community and allow people to have more control and choice about where they receive that care. And that is something that we are absolutely committed to working with our local authorities to achieve and have really good engagement with our Association of Directors of Children's Services and Directors of Adult Services to really consider the type of marketplace that we want in the North East and North Cumbria for people to have that choice over where they receive their care and support from.
Thank you. Well, thank you, Hilary and Kate, for the presentation and the topic being highlighted to the board. I think we've discussed this before, so it's very helpful to know what's happening. So thank you very much indeed. Moving on then to, I think we're on the primary care urgent dental access recovery plan. I don't think there's an acronym for that, but we'll work on it during the discussion. Dave Gallagher.
Yeah, I'm sure we can make one up, Chair, but we'll not. Thank you. So this very brief paper set in the context of some much wider work that we've been doing for the last year or so across North East North Cumbria, which will culminate in a broader picture coming to the board in July. The reason for it coming in July is we just had a stakeholder event yesterday to finalise some of that and to make sure we're representing people's views in it. But this paper focuses very much on urgent access to dental care. And in the broader work that we've been doing, one of the key messages that we've got from complaints, from MPs, from the media, but most importantly from the public, and the public through Health Watch, and Health Watch have been really, really helpful with this, is that people want access to urgent care. So it's not the routine follow-up checkups, it's actually, I've got toothache, I need a tooth extraction or whatever, we need to get into that. So, like a lot of papers that come to board, there's a huge amount of work underneath the paper, but to cut a very long story quite short, the team have been working to actually develop a model for access to this urgent care. We started last year and piloted 2 UDACs, urgent dentistry access clinics, I can't get my teeth around that, which were focused in Darlington and then latterly in Carlisle. Those have proven very, very popular. Again, we've done some work with Health Watch and got some evaluation from patients and stakeholders. And just this week, I saw some evaluation that's been shared nationally on the one in Darlington, which shows that it's the right thing to do. So we've got a model. We're adding that model to some of the shorter term interventions that we've had. So we've had incentivised access. Ironic for a dental one, isn't it? I can't get my teeth around this at all. An incentivised access scheme. We've also increased the number of out-of-hours sessions for urgent access by 1,134, and we've increased the clinical triage through 111. But the more sustainable model is this urgent access. So building on the 2 centres that we've got, we've now developed an approach, and we've got an ambition to set up 30 of these surgeries across North East North Cumbria, strategically placed. Some will be standalone, as the 2 we've got, but a lot of them will be actually integrated into current dental surgeries. So the paper includes a list of 9 or 10 locations that we've got across the patch that have been implemented already this year. So the team have been working great guns with the providers to get to this, and we've got conversations going on to get towards that 30 services across the North East and North Cumbria. All of this has been agreed through the Primary Care Committee and the Executive Committee, and what it will do is actually give us 109,000 extra new appointments for urgent access to dentistry. There's a national ask from the government. There's a sum of 700,000 urgent access appointments across England, which equates to us in North East North Cumbria to 57,500. So we're well surpassed that. We have got an interesting dilemma in that the way it's being measured nationally is not necessarily on the appointments available. It's using some of the FP10s, which actually describes the outcomes from this, and there's a little bit of a mismatch. So going forward, and we'll see it in the delivery report, we're going to measure both, because we're we've got to put the opportunity in there, but within the mix of contracts being handed back, we'll lose some as well. So very much a mixed economy as we move through this, but it's brought to the board for information, for assurance that actually the team are well on with this, that progress is being made. But as I say, it'll come back in the wider context of a whole oral health strategy that links in the promotion, prevention and also access to more routine dental care. So happy to take any questions, Chair.
Thank you. Mike Smith.
This sounds overwhelmingly positive and meeting a real need that our patients have. I guess one concern, is there any risk that this displaces preventative work, and what we end up doing is prioritising treating people who have got bad dentition and problems with that, rather than stopping them from ending up in that position in the first place?
Yeah, it's a really good question, Mike, and there's a risk as we try to balance this. So we've got practices handing contracts back. We're shifting some of the practices to focus more on the urgent stuff, but that could be at the detriment of the more routine bit. I guess the challenge that the team have got and the practices have got is getting that middle ground. So there's the prevention, promotion bit, the scale and polish. There's then the group of patients that you're talking about, and then the urgent ones. And we just need to try and balance that as we go forward.
Christopher Ackers-Belcher.
Thank you, Chair. Thank you for the report. It was really welcome, bearing in mind, I know you referenced Health Watch, and bearing in mind we had 3,500 people responded to the consultation, but the UDAC model, obviously the feedback from both Darlington and North Cumbria has been very positive, and to see the fact that there's going to be a further 9 initially. But what I want to mention was the web page that's going to be launched, because I think from a public perception point of view, that's going to be really a positive move. And I think we need to have, lots of communication around that, and Healthwatch more than happy to support in that, making sure that we feedback to everybody who we engaged with. And it's still quite challenging probably to get that up and running for July, August time.
Yeah, that offer of help's really helpful. One of the things we didn't want to do, and we've been really cautious about this, is blowing the trumpet and saying these centres are open, because what we didn't want to do is get them swamped by activity. So we're trying to do a bit of a soft launch with some of this, and colleagues are helping us with that. But as we get into the summer and we've got more of these centres open, then actually we'll be doing that. And the web bit is really important, Christopher, because one of the biggest challenges is actually signposting people to the right place. These centres won't necessarily be your normal dentist. It's a bit like going to A&E, if you like, where you'd go to the nearest one or a choice of one. So, yeah, signposting is really important. But again, help with that from Health Watch would be greatly received. Christopher, thank you. David Stout.
Yeah, thank you very much, David. And it's really welcome to see the development of the UDACs. That's excellent. Is it still true to say that we'll never really make real progress around dentistry until we actually have a new national dental contract that's adequately resourced? Is that still, are we still locally doing the best we can within that constraint? And if that is the case, then is that constraint, is there any likelihood of that constraint being dissipated?
Yeah, thanks, David. And that's really astute comment, because what the team are doing is working with the constraints we've got and things we've got influence over. So they're working nationally on this. They're actually playing into the model for urgent access, but one of the key limiting factors is the archaic contract that's there. So there's lots of work being done to lobby for that nationally, and I'm optimistic that at some point something will happen, but it probably can't happen quickly enough, to be fair.
It's been a long time coming, David. That's when you come out.
Indeed.
Rajesh Rakani.
Thanks, David. I think this is really excellent work. My question was, is there any learning from this which we could apply to any other burden of need? Because dental care has got a lot of relationship with inequalities too. So is there anything you learned, or was it just a matter of contracting and practices who are willing?
I think the contracting and practices are willing are getting towards the solution, but absolutely we've focused the attention on areas of greatest need, and a lot of that is areas of deprivation. But you could apply that, and it'd be good to be able to step back from this and see if we could apply that to other learning when we get further through this.
David Chandler.
Yeah, thank you, Chair. Thank you, David. Just a quick one. You know, in the report we talk about residents will be able to access any UDAC, and those who can travel will be able to go to different monitoring patches. I was just thinking there about health inequalities and deprivation. So are you able to tell a little bit more about the thought process in terms of where they get sighted, because not everybody obviously can travel?
Yeah, thanks, David. So we've tried to focus on the areas of greatest need, which includes the areas where people are less able to travel. The rate limiting factor of that is where we've actually got the ability to provide the services. So Cumbria is probably a really good example where actually there's quite vast geography. The road system isn't very good, as we know, and the transport system is not very good. So there's one in Carlisle. We'll be putting one further out to the west, but people will need to travel. And it's just trying to get that balance of access to something, but there's a need to travel. It is something we need to work at, because it's some of the feedback we've had. But you'll see from the list so far, we've tried to position these strategically across North East and North Cumbria to enable easier access than having to travel a great distance.
Thank you. Sam Allen.
Thank you, Chair. Dave, I mean, it's just fantastic work from the dental commissioning team. They've really pulled out all the stops on this. I was just thinking about where the connection is with our training strategy for future dentists and other colleagues, because presumably these centres will have a kind of a concentration of urgent dental work going through it, and there'll be really good training opportunities there. Are we linking in on the workforce side and the education side?
Yeah, thanks, Sam. Yeah, we've been working with the deanery. We're working with particularly the dental hospital as part of Newcastle University, and they've provided some input into the wider work as well, but they are looking at that. Interestingly, talking to some of the dentists working in these centres, a lot of them are saying this is actually what they're trained for. This is more interesting, more enriching jobs. So I think there is something there that will help the workforce shortage in time, not immediately.
If I may just really quickly, Chair, I wonder whether over the course over the next 3 to 6 months, members of the board should go and visit one of these UDACs just to talk to colleagues in them and have the opportunity to interact with any patients who are accessing them as well.
Yeah, we can happily do that. As I said, we're being a bit cautious until we get them up and running, but certainly the Darlington and the Carlisle ones are reasonably well established now, so there'll be an opportunity to do that, and happy to coordinate that if people want to come forward. Thank you.
Just one question from me, Dave. Do we have anything that we use as a denominator? Because it's good to see the increase in numbers, but it doesn't give me an impression whether how deeply we're dipping into the pool of need and demand. And I realise that those data are probably not routinely collected, but if you want to make an assessment of how much of the serious unmet need we'd been able to meet, would you be able to put a number on it, or not really, a percentage on it?
It would be very hard to do it exactly for the reasons you've described, Chair, but we've deliberately, as you'll see from the numbers versus the national challenge, we've well surpassed what the ask was from government, because we know the need's quite high. The data's not that sophisticated at the moment. There's more work we need to do, probably a bit like the conversation we just had about general practice data. There's more information required on dentistry and the need.
I think, I mean, the only other, apart from wanting to get a feel for it, the other point is David Stout's point that if you wanted to advocate for more rapid action on the national contract, then being able to show how much, even despite everything else that's being done, it isn't yet making sufficient inroads to make a difference to the large number of people being treated. Yeah. Okay, thank you very much indeed for that report, and it's good. We've discussed the issue of dentistry very regularly on our agendas over the last couple of years, so it's good to see the progress. We're moving on now to the medicines optimisation strategy, which Neil O'Brien's going to introduce, and with him are Ewan Maul and Kate Haddart, Director of Medicines and Pharmacy and Deputy Director of Medicines and Pharmacy.
Thank you, Chair. So yes, I'll be very brief. Just to really congratulate the team on pulling this together. Just one thing I would like to highlight when both Ewan and Kate go through the strategy is the alignment with the clinical condition strategic plan, both in its format, in the way in which it's presented, the very kind of practical, measurable way in which it's written and set out, and the alignment to the main conditions for both adults and children as a quality improvement tool to try and get better outcomes for those conditions that do affect our population most. But I'll just hand you over to Ewan and Kate. Thanks.
Thanks very much. So thanks for the opportunity to present this today. What you'll see today is a very short extract of what's a much more detailed plan. We've deliberately kept it brief for the purposes of today, but there's much more detail that sits behind it. So, as Neil said, I've got Kate with me, and I'm glad Kate's able to be here because she's driven an awful lot of this work, so it's nice to be able to get to the point of presenting it. Apologies if I have to keep taking my glasses on and off to be able to read my notes on the screen at the same time. So we know that with growing demand and with ever tighter resources, medicines need to be a really central commissioning consideration. And we need to start to see it as an investment rather than expenditure. And by that, I mean we can either use that investment very well and seriously improve population health outcomes and reduce inequalities, or we can make them worse. Now, this strategy was originally written a couple of months ago, and it predates all the announcements about change to ICB functioning and moving towards strategic commissioning and some of that clarification. But actually, I think it's still valid. It hasn't changed since that announcement because everything in it is still perfectly valid in terms of strategic commissioning of medicines. It's a 5-year strategy. Some of the detail in it might change over the course of those 5 years. Some of the specific measurables and things like that might change depending on progress and what emerges. But actually, what we're trying to achieve won't change. And hopefully, what you'll see as we go through the presentation is how we aim to use medicines as a lever to achieve better health and well-being for all and support the 3 shifts that we all know that we're expecting to move towards. So medicines are the most common and evidence-based intervention in healthcare. So we need to use it wisely. And depending on how we do that, as I say, we can either seriously improve the health and well-being of our population or we can adversely affect that. So it's a challenge of value, safety and inequality. And at a strategic commissioning level, we need to make sure we're supporting the delivery of the clinical conditions strategic plan, as Neil said, and there are very close alignments between the two, as you'll see when we come on to the detail later on. So we know that at the moment that we have unwarranted variation, we know that we are not using medicines as well as we possibly could do, and we also have made significant strides towards, but are still not perfect, in making good decisions about medicines at all levels. So I'm talking about patients making decisions about their medicines, clinicians when interacting with patients, but also at organisational level and at system level. We need to make the right environment, the right culture, the right behaviours at all these levels if we're really going to see the shifts that we need to see. And in doing that, we'll narrow the health inequalities gap, but what we'll also deliver is patient-centred care and will enable and empower patients to be able to take a role in their own care as well. So the scale of the challenge is sometimes a little bit staggering, off-putting, intimidating. Clearly, with 7.5 million prescriptions being issued every single month in primary care settings alone, so that's not including all the activity in secondary care, we cannot intervene, we cannot control, we cannot direct each of those 7.5 million prescriptions every month. So it is much more about the system, the governance, the way we commission things, the environment that we set for this stuff to happen well. And a lot of that is about culture, behaviours, as I say, both patients and clinicians. So we need to create that right environment. There's lots of evidence as a system that we over-prescribe and over-medicalise. So if we look at the polypharmacy example there, we've got obviously more people living longer and more people taking more medicines for longer. And what we seem to be very good at as a system and as a culture is adding more medicines in and far less good at taking medicines off, and even less good at using non-medicines as an option. So we prescribe, I think Cyrus used the phrase about prescribing being a pressure valve for all the other parts in the system. When the other things are not working, we default to the prescription pad because it's the only thing we've got. So we prescribe too much, but also what we've got evidence of is that people are not as involved in decisions about their treatment as they would like to be. So again, we're being slightly paternalistic in saying, here's a medicine, and actually raising the expectation that the medicine will solve the problem, when actually very often that's not the case. So it's an issue of over-medicalisation. It's also an issue of safety. We've got 79,000 patients taking long-term opioids in our system. We know that that's not evidence-based. We know that the harm outweighs the good in an awful lot of those patients, if not most of those patients. So we are not just not doing the right thing for our patients, we are often causing harm as well. 13% of the population take antidepressants. Now, it's not possible to say whether that's the right level, too high, too low, but what we do know is that antidepressants are very often used as an immediate intervention when access to non-pharmacological therapies may be more appropriate, but waiting lists are so long that inevitably, when people are looking for a solution, that's what we default to. And we've got fairly high levels of use in children and young people as well, which is obviously concerning for the future. And we haven't done the shift from treatment to prevention very well. So as an example, we overuse treatment inhalers rather than prevention inhalers. So we are not supporting people to get the best use out of the medicines that are being used for prevention as well. So we decided we needed to galvanise the system around a set of priorities, a set of clinical priorities, and make that common and shared across the system so that regardless of where somebody was working and where somebody was practicing, where somebody was accessing health, they would all have the same understanding of what the system priorities were. So as Neil said, we did follow the same approach that we took to the clinical conditions strategic plan. So we used population health management approach, considered the areas that most adversely affected our populations, that had greatest room for improvement, and areas where there was a clear case that both clinical services and improving prescribing would improve outcomes. So the initial bit of work we did was within our team to develop a broad set of priorities. We did extensive engagement with various different clinical groups early on. And then when we felt we had that at a point, we then decided to be very public and get a lot of engagement from across the system, patients, public, patient representative groups and so on. So we started off with a webinar in January with over 180 people on it. And we presented it and we sought feedback at that point. We then followed that up with a survey, which had 64 responses. And a part of that survey was a question of, if there's anything you would like to discuss more, please let us know. We had 14 people who requested a further conversation. So in the team, we contacted every single one of those 14 people and spoke through, sometimes in quite a lot of detail, about what their thoughts were on our proposals. And you can see some of the feedback there. So the strategy genuinely did change as a result of that process. So I think it was a really worthwhile exercise because it brought us to the point that we're at and helped to kind of shave off some of the edges that perhaps weren't quite right in the first place. So these are the areas that we've landed upon. So you will notice that significant overlap with the clinical conditions strategic plan. So areas like analgesia, CVD and diabetes, respiratory, anxiety and depression, there's all obvious overlap there. But there's also the introduction of some things that are global health priorities. So antimicrobial stewardship as a prime example. Obviously, opioid use falls under analgesia. And then as a national strategy was a national overprescribing review done a few years ago, and we know for the reasons that I've indicated before that needs to be one of our priorities as well. So there's much more detail in the final document about each one of these. The way that the strategy is structured is that for each one of these strategic priorities, we've got 3 sections. So 1, what the data tells us, 2, what we're looking to do to improve it, and 3, what we intend to measure so that we'll know that what we've done has actually made a difference. It's a 5-year strategy, and what we intend to do is to bring an annual report back through the clinical effectiveness group on the measures and the improvement, hopefully the improvement in the measures that we've seen as a result of this work. So to illustrate that, I've just picked one section. So I've picked the overprescribing section that I'll take you through at a very high level just so you can see the detail of it. So what the data tells us, from national data, we know that 10% of prescriptions or 10% of medicines on prescription are loosely categorised as overprescribed. So that might be something that's prescribed that a patient doesn't take, doesn't want, doesn't need, or is actually actively doing them harm. Should point out that £300 million wasted is actually a national figure, that's not ours, but as a national figure, so we are obviously a fairly significant proportion of that. And you can see what tackling this would do. It would help us really not just save money, it would help with net zero targets as well. And the harm that we are doing by overprescribing is very significant, and there are significant inequalities there. So almost 3 times higher rates of polypharmacy in the most deprived areas. So that's a really, really significant amount of harm we're doing to our most deprived populations. So we could summarise what we want to do about overprescribing with that box on the left. We want to make the decision to stop a medicine as commonplace as the decision to start a medicine. And I think that's the thing we've got to keep in our mind. There's lots of different ways we've got to do it, and obviously I won't go into all the detail about how we plan to do it, but you can see we've had some really great success in the past with behaviour change campaigns, stuff around opioids, antimicrobials and things like that. So those are the sorts of approaches that we want to use to start to change the public and clinician narrative and understanding and expectation. But the other thing that we need to do if we're going to address this is to look at some of those wider system pressures. So going back to Cyrus' point about prescribing being a pressure valve, we need to improve access to non-pharmacological options. We know that access to all kinds of healthcare, waiting lists and so on drives up prescribing and quite often inappropriate or harmful prescribing. So we need to get to the point where stopping a medicine is as normal as starting a medicine. Of course, measuring it is quite difficult because if you're talking about 7.5 million prescriptions a month, how on earth do you measure what's appropriate, what's inappropriate, and how you've made improvement in that? So the way that we're starting off measuring it is looking at people who are over the age of 75 who are prescribed 10 or more medicines. And I think that's probably the right measure to start off with. Now, we want to look at these huge data sets that we have and turn them into really practical, actionable interventions and intelligence and insights at all levels, so at system level, at organisational level, but also at individual prescriber level and clinician level as well. So there are lots of ways that we can do that. I'm really excited about the opportunities that AI might bring us in that space because I think that's something that we could do huge amounts with. One of the main tools we've had to drive improvement in the past has been prescribing incentive schemes, but obviously coming from 8 different CCGs, we had a multitude of different approaches to those. So we've recently commissioned a review into those prescribing incentive schemes, and we're going to take the intelligence from that to help us design a new model. What's worked, what hasn't worked, where have we seen over 5 years a genuine impact from that. So that's a very high level summary of one of the sections. There's much more detail in it. But what's clear is that there are some significant opportunities for us at the moment, and there are lots of reasons why this is a good time to be doing it. So I mentioned technology. We've also got some other really important things like pharmacogenomics over the next 5 to 10 years is going to completely revolutionise care because you'll be able to personalise care, and that will fundamentally change the relationship between a person and their medicines. But we've also got other things more immediately like workforce development. So as of next year, all pharmacists coming out of university will be independent prescribers. That fundamentally changes the way that we can deliver certain parts of care. And there are lots of other things that are exciting specific to this region. For example, the Medicines Manufacturing Centre that's being developed in Seaton Delaval. But of course there are barriers, there are risks, there are challenges. One of the main ones being the medicine supply chain is extremely fragile and a huge amount of time and effort is taken up by everybody in the system in managing that. A lot of it requires cultural change, which is why this is a 5-year strategy, not a 1-year strategy. And of course it's always easier to spend more money than it is to not spend money. And that's one of the challenges we've got to get is how do we invest in the right things? How do we invest both medicines and how do we invest in non-medicines to ensure that we're getting the greatest impact? But we see this as a core strategic commissioning ambition for medicines across the system for the next 5 years. And I think it's one of the ICB's clearest opportunities to reduce harm, improve equity and spend wisely. So happy to take any questions or reflections on that.
Thank you, Ewan. A very interesting subject. Can we just clarify one thing to begin with? It might be that Sam would want to answer this. This is one of the areas in the Model ICB report that it suggested that ICBs don't deal with in the future. And so linked to that is the question, given all the areas that you've laid out where action's needed and we're already engaged with a lot of them, is there anything that says that any of them couldn't be done through strategic commissioning?
Well, I'll just make a start, but I'm going to hand over to Ewan because Ewan's been very instrumental in informing the national discussion on this with other ICB directors and medicine chief pharmacists as well. I think the functions that are listed for transfer in the model ICB blueprint need some further thinking through, and I think medicines management is a really good example of this. So whilst I think on the one hand one could think actually this is something that providers can do, I think actually the strategy that Ewan's laid out really clearly demonstrates the commissioning function and role in the utilisation of medicines to support improved population health. I think it's not to say we're not open to change and the exploration of that, but I think with £1 billion worth of spend at the moment, we believe we can drive best value across a population of 3.1 million rather than fragmenting this up into smaller pieces. But I'm going to hand over to you, Ewan, and I think you should certainly share the thinking you and other colleagues in your position across other ICBs have been having on this.
Yeah, thanks, Sam. So the document, the National Blueprint, talked about delivery of medicines optimisation being transferred but retaining a strategic function, and I think that's one of the reasons why I think what we've presented today is about a strategic function. The how that's delivered, there's lots of different ways that can be delivered, and it might be completely different in different places, and we are very open to exploring different models. One of the reasons we've done the review of the incentive scheme is to say, well, actually, we've got years of experience of doing this. What works best? What do we need to promote? As a group of ICB chief pharmacists across the country, we've developed a medicines optimisation blueprint, which looks at all of our functions and does try to identify which of those we should grow, which we should retain, and which we think should transfer. I think we're very open to doing things differently, and I think some things we need to do differently, but while we've still got responsibility for clinical risk and financial risk across the system and outcomes, I think there's still too much in medicines that we would want to retain to be able to delegate that completely.
Thank you. Graham Evans.
Thank you, Chairman. Thank you, Ewan. Really detailed overview. It's linked to Sam's comment and looking at some of the opportunities with developments of the use of the NHS app, the left shift, putting patients more in control of their healthcare, the utilisation of artificial intelligence going forward. But on the flip side, one of the key barriers seems to be the lack of interoperability between healthcare records, the utilisation of the Great North Care Record. So to what extent are the barriers inhibiting some of the opportunities? And again, the role of integrated care boards going forward, how do we get the right level of digital enablement for these key areas of priority?
I think that's a huge barrier, but a huge opportunity as well. One of the main ones at the minute being the ability to issue a prescription from a hospital to a community pharmacy. Seems like a really obvious thing to do. I spoke to a lady yesterday who got a prescription for her daughter sent by taxi from a hospital 60 miles, and when it arrived it was a bottle of Gaviscon that she would have quite happily bought if she'd known that's what it was. That sort of thing is just bonkers, and that's a lack of digital interoperability that's doing that, so that's absolutely an enabler to doing this stuff better.
You learn a lot from taxi drivers. I learned from one who was transporting medicines of a medicine that was sent something like 30 miles from one trust to the other, where the patient lived nearer to the trust where it was being sent from than the one it was going to. But yeah, David Chandler.
I do wonder, Chair, we should consider whether a taxi driver could join the board in the future. That might be something to consider. But thank you for presenting, Ewan. Really great presentation, really clear, really well laid out, really helpful. So just a couple of comments and a couple of questions, if I've added up correctly. So first of all, I'm really glad you mentioned about the importance of culture. So not just what we're going to do, because there's so many prescribers, so many patients. Culturally, that's the biggest barrier, I think, in terms of what you're trying to do here. So I'm really glad you talked about that. And you talked about some of the measures you would do in that, which I did think you'll be coming to me at some point and saying to do that, we might need some money. So, but it's important, isn't it, on the cultural side? And AI as well, glad you mentioned that as well, because I think there are definitely going to be opportunities in that space. In the slide pack, and in the papers on page 349, you've got a cost impact slide there. And as we were saying earlier, Sarah was talking about the importance of being really clear on the outcomes and what they think the benefits are going to be in any form of change that we do, given our limited resources. So I'm pretty sure you're going to be firming that up as part of the strategy in terms of what the benefits are going to be. On the cost side of it, I think you can sort of say there are some areas we expect to save money or reduce waste, as you just talked about polypharmacy. And I imagine they'll go into cost improvement schemes for future years, and I'd recommend that. I know that obviously in CVD and diabetes, I think you're more or less saying we might need to invest in there as part of left shift, prevention rather than treatment, which I totally understand. Obviously, when I see two big red arrows, that gives me heart palpitations as an accountant, and you'll be pleased to know I'm not going to come asking for a prescription for that, but more assurance in terms of we will cost up what we think we need and when we need it, and what the benefits will be, so that we can identify where's the biggest bang for our buck for any resources that we can put into left shift. And obviously we talked earlier today about having a fund in that space so that we can do that sensibly, so we invest in the right things at the right time. So just a quick reflection that you've nodded at the right time anyway. And the last one was just going to be about community pharmacy. So I hear a lot about the vulnerability of community pharmacy, and I just wonder if that's going to be part of the strategy in terms of how do we support that. Thank you.
Yeah, so on the finance part of it, you're absolutely right. The majority of the strategy is directly cost saving in terms of the prescribing budget. There are some things that are not. So CVD, diabetes, things like that, it will cost more money. But the reality of the situation is, with 300 and odds general practices out there, countless trusts, we can't tell them not to prescribe evidence-based medicines for diabetes. We wouldn't want to. What we do want to do is make sure they're using them properly, that they're getting the outcomes that we expected to see. And I think we met as a senior team yesterday and talked about how much our focus needs to shift from just looking at the prescribing to looking at the prescribing and the outcomes, and have, for those areas where we have invested, have we seen what we would like to see back as an outcome? And are we assured that those prescriptions are going to the right people in the right way? And I think that's the key for us, because at the moment we see vast increases in areas of spend in diabetes, as an example. Are we using them in the right people? Are we doing all the wraparound care that we need to be doing to make sure that they get the right benefit from it? At the moment, it's difficult to say. So I think that's the area that we need to get into. So those big red arrows are conscious and well planned, and that we're seeing the benefits for the big red arrows. I think that's the first point. I think the second point about community pharmacy, absolutely valid. They are vulnerable at the moment, and there are obviously there's a national contract which we have relatively little influence in. What I would say is that we can and should be commissioning more locally from community pharmacy. I think for a variety of reasons. I think it's accessible on the high street. I heard part of the conversation about dental earlier, and actually quite often the most accessible healthcare provider is the community pharmacy on the high street. So make it as easy as possible for people to get services from there. But I said earlier, as of next year, they're all going to be coming out as independent prescribers. So at the moment, they're relatively limited in the services they can provide. That's going to change massively over the next few years. We just need to make sure they're all still there to be able to do it in the next few years.
Lisa Taylor.
Thank you. It was a really good strategy, and I love the way it's linked to the medical condition strategy as well. Just to, one comment and one question, if I may. Regarding the culture shift that's necessary, we've got a VCSE network that spans the whole of the ICS, so would really be interested in supporting you to do a bit of culture change work through the network. And the question was just about the most deprived areas where you talked about the high instances of polypharmacy. Do we know how much of that is due to overprescribing and how much is due to genuine medical needs due to higher prevalence of medical conditions in the most deprived areas?
I think obviously in deprived areas there is more medical need because we've got more prevalence of disease and things, but we're working through that data to understand. Some of it needs unpicking though on a clinical patient by patient level, and that's taken a bit of time. So there is national figures, but for local figures I think we need to delve into it a bit more for that. But I think it's something we're definitely looking into.
Sam.
Thank you, Chair. I mean, I just think it's such a fascinating subject, and it's a really important conversation we're having. I think the fact that £1 billion of our overall budget is spent on medicines is hugely significant. And I think the way in which the strategy has a real focus on population health improvement and prevention is key. I'm really conscious that we're going to have a item shortly on neighbourhood health and thinking about your focus on frailty. We have an ageing population being absolutely critical. My question really, I've got two questions, a comment and a question. Firstly, are we being ambitious enough around the type of partnerships we need to have with the pharmaceutical sector? We've done something quite exciting recently with Boehringer Ingelheim around kidney disease medication. Where do you kind of see the future opportunities there for our population? And then secondly, what more do you think, builds on Lisa's point, do we need to do to increase sort of citizen and patient empowerment in this area, both in terms of the polypharmacy issue, understanding the cost, the waste? Where do you see the opportunities there, Kate and Ewan?
I think that the first point about pharma is a valid point. I think we need to reset the relationship with pharma for a variety of reasons. One, they're the supplier of our goods. What industry doesn't have a good relationship with the supplier of their goods? And we know that supply is challenged. We know that there are challenges nationally with pharma investing in the life sciences industry in the UK for a variety of reasons. So we need to reset the relationship. And I think as in the NHS, we often have potentially outdated views of some of the bad behaviours of pharma in the past. But actually the codes that are in place now really do prevent some of those, all of those excesses happening. So I think we do have to reset that relationship, and they have a capacity and a level of expertise in things that we don't have. So I think we have to start to do that. I think, what was the second point again? Sorry, I should have written it down.
Patient and citizen empowerment.
A big part of this, I think, is understanding our population. And I referenced earlier the behaviour change interventions that we've done in the past. In my view, the reason they've been so successful is because we didn't just do it as a comms campaign of stick some posters up in GP waiting rooms. We took the time to properly understand the populations where the need was greatest. So we did a lot of insight work and understood those populations and heard from them and designed things appropriately, or co-created things with them. And I think that's where we need to be for some of these priorities, because, again, going back to the paternalistic point, if we tell them what we think they should do, then we're on to a loser. We need to ask them and co-create with them.
Mike Smith.
Thank you both for an excellent strategy. I agree with every single one of the outcome measures that you've outlined. I think they're really positive and really thoughtful. I guess on the cost impact screen that David was also a little bit concerned about the red in. I'm a bit concerned about the greys as well, that the in-year costs for a lot of these are negative straight away. As you said, you'd like to make de-prescribing as common as prescribing. In my experience clinically, de-prescribing is 10 times harder than prescribing because you've really got to work through that journey with the patient to unpack why it's a good idea, make the case for it, fully understand that it is the right case for that patient, and then go through with it, follow it up. It takes a lot of time. And each of these areas, both for polypharmacy, antimicrobials, analgesia, respiratory, they're all big areas of medicine. We've got large numbers of patients in these cohorts. So it's going to be a huge amount of work, and predominantly it's going to fall on primary care, who are not blessed with huge amount of spare capacity to do a lot of this work. So I guess there's a few aspects of my question, really. The main fundamental point is, do we have the money to be able to pay to do all of this? And if we are, can we make sure it's set up in such a way that it's sustainable? So a 1-year incentive program doesn't really help, because then you can't employ staff in order to deliver that in the longer term. And we can't, if we redeploy staff, then we're going to have to stop doing something else, and we have to make a strategic decision. Is that what we want to do? So just whether you've got any thoughts on how that can play out. But just one additional thought is that I'm also fully on board with the co-creating and getting citizens where they to that point of understanding as well. It makes the job of the practitioner 100 times easier if the patient in front of them accepts that de-prescribing is the right thing to do from the off. So if you're not trying to make that part of the argument because they already understand that, it makes it a lot quicker.
And that's what we found with opioids, was that if you as a clinician call a patient in and say, we want to talk about stopping your morphine, that's very different from a patient contacting you and saying, I don't think this morphine is making me feel very well, would you help me come off it? It's a very different conversation. I think you're absolutely right about the way we've commissioned incentive schemes and things. And in the past, we have done single year, quite transactional things, which we've found might have achieved something in the short term, but actually have no long-term benefit, no long-term sustainability. Again, if you look at opioids and antibiotics, we've seen a continuous downward trend for both of them now for 5 to 10 years. That's a sign that consistency helps, that consistency of message and supporting the clinicians along with changing the culture and the expectation of the patients. That's the way to drive that long-term sustainable change. And I think that for overprescribing is the next big challenge. In terms of deprescribing itself, there is some deprescribing that's really difficult, but there's some that's really easy, because there are some where actually, if you just ask a patient if they're genuinely taking the drug or not, they're probably not. And so there's a lot of that stuff that can be done quite easily and quite quickly, but then there's the really difficult stuff as well. So I think you're right. The delivery method will be different in different places. The delivery method is the bit that we haven't designed yet, and that's the bit we need to co-create with the people who will be delivering it to make sure that it is sustainable and impactful and achievable.
Claire Riley.
Thank you, Chair, and thank you, Ewan and Kate, for an excellent presentation. I really do like the strategic plan on a page, and those 6 priorities are obviously key to the delivery of this strategy. Each of them require quite a considerable amount of behavioural change, actually, and also the winning of the hearts and minds of the communities and the population. We've learned a lot through some of our work recently from a behavioural change and communications point of view, and recognising there's also a cost-benefit analysis of that work, where people generally see it as a cost, but actually what they don't see is the savings that it generates from a system point of view. So I'm assuming the opportunity is real, that we can have a corresponding social marketing and communications and engagement plan to actually support the key components of this strategy going forward, so we can be really clear on the timeline for delivery. And what would be really helpful, I think, is then seeing how that generates the savings required as part of the overall opportunities detailed within the strategy. But I think it'll be really good to work on that, because I think there's a real opportunity of changing the narrative around how the functions like communications and social marketing can work operationally with clinical services.
Yeah, and I've mentioned it several times before. I think that's absolutely key. We can provide our expertise and our insight, but there are lots of things other people are better than us at doing, and we need to work alongside them.
Tom Hall.
Yeah, thanks, and excellent strategy. I couldn't agree more with the cultural shift element of it all, building on what Claire's just referenced in terms of changing hearts and minds on some of this. I noticed in the strategy you referenced quite heavily patients and prescribers as part of that, but I was also wondering about carers, adult carers, and obviously young carers as well, and then also thinking about parents, especially those that are new to the world of parenting, and just thinking about what integration opportunities there are in the social marketing work around things like family hubs, parenting programs, and also thinking about carer services that local authorities commission as well. I think there's some real join-up opportunities there.
Just one question from me, Ewan. Metrics. Is there there hasn't been a great fashion in healthcare for composite metrics, which are methodologically very difficult and people dispute them all the time. But has anybody come up or attempted to come up with a single measure of over-prescribing, a number, a percentage or something, which could be used for comparing?
Not really, because over-prescribing is quite a difficult term. And actually, for lots of prescribing, there is no right amount. So we look at prescribing data and we say generally fewer opioids is good, more preventative treatment for diabetes is good. But it's very difficult to say what's the right level for a population. So, for example, if you compare the prescribing from a general practice in Stockton with one in Jesmond, by the nature of the conditions and the people that they're caring for, they will have very different levels. It's very difficult to say what is the right level for each of those. But I think that's the world that we need to start to get into. That's the big gap for us. And that's where I'm hoping that things like AI will help us with some of those more complex things that we've just not been able to do, frankly. We look too much at prescribing data in isolation from the wider picture.
Thank you. Neil, is there anything you want to say by way of conclusion?
No, just I think some really good feedback and comments. I've just been sitting reflecting. I think the comms plan, but also I think maybe for this and for the clinical condition strategic plan, what would add some weight to it would be that financial strategy, investment and long-term savings. So we could maybe do that piece of work for both of those strategic plans together. But no, really good discussion. Thank you, and thank you, Ewan and Kate.
Well, thank you both. As ever, a very, very interesting subject. And, oh yes, we've got to approve. So everybody approve the plan? Good. Okay, we like approving things. So what are we on to next? Oh yeah, the neighbourhood health. Levi.
Great, thank you, Chair. And quite a nice paper to finish on, I think. I think it pulls together quite a lot of the themes we've talked about today. What will the shift in landscape look like in health and social care? The links we've just heard to meds optimisation. How do we use data to drive our decision making, and some of that balance between our strategic commissioning role and the provider market. So it's a fairly extensive paper, but for board colleagues, this will build on a lot of the discussion we had at the development workshop in April, where I was accompanied by Dr. Cowie and Dr. Steele, who were able to give the board an insight into applying this kind of approach, thinking of a frailty group. So I'm just going to walk you through some of the key themes here, and again, hopefully make those connections with other things we've talked about. What's probably worth mentioning over the last probably 2 or 3 months is quite a range of activity that's helped us move this model on. So we had a recent frailty conference with over 300 people attending, hosted through our Boost and Learning Improvement platform. We've had a shared UEC, Urgent Emergency Care and Neighbourhood Health workshop. Our Living and Ageing Well partnership, which is our key forum, continues to drive this forward. It's actually meeting this afternoon. That includes partners from local authorities, general practice, our foundation trust, VCSE, mental health, a very extensive group. As well as all the work that's happening on the ground within our local delivery teams. So the paper describes that neighbourhood health is pretty much the defining organising principle for how care is going to be delivered in communities. This is reflected in the 25-26 NHS planning guidance, and although we've not yet seen the 10-year plan, everything we've heard so far really seems to indicate that neighbourhood health will continue to be a real core focus there. And it links again with Graham talked earlier about our digital inclusion strategy. It all supports the left shift, our continued focus on from treatment to prevention, from analogue to digital, and from hospital to community settings. Again, you've heard me talk about this in board before. It's not a new shiny concept. This is really about getting the momentum and the clarity of purpose behind neighbourhood health, and a more consistent framework developed with our partners, and thinking about the future ICB role really being around that system-wide intelligence, the data insights, setting the commissioning framework with specified outcomes, but with the delivery and implementation perhaps being managed in a slightly different way in the future. So section 3 of the paper sets out for you the national and regional context for this work. Again, left shift, it confirms alignment with our Better Care Fund policy and the National Neighbourhood Health Guidance. And the appendix, I think it's Appendix 4, which has the slide set, which you can look at your leisure, really illustrates the 6 core components that underpin our neighbourhood health approach. So they are population health management, modern general practice, standardising our community services, neighbourhood multidisciplinary teams, integrated intermediate care, and urgent neighbourhood services. And again, the appendices, I think, give you an illustration of where those different bits of the system will fit together. Very framed within our wider urgent and emergency care and our core coordination centres are single points of contact. So it's part of it, it's a concept around a number of our building blocks. Section 4 takes you through a little bit more detail on our data and how is that data driving our population focus. And what that's told us so far is it really reiterates a system-wide focus on older people, 65 plus, with complex needs and frailty. Again, echoing a little what we've just heard from the Meds Optimisation team. It highlights the importance of using this data to anticipate and respond to our need, and continues that theme of moving from reactive to proactive care. Hopefully the data conveys to you that whilst that frailty and comorbid group is key in terms of making an early intervention that leads to better outcomes and experience and has the consequence of reducing use of hospital services, the driver is about doing the right thing for the patients. The benefit is where we see impact on capacity and flow. But we've also continued to look at other focus groups. So long-term conditions come through there, whether we're looking through diabetes management, cardiovascular, but also you'll pick up in the paper, there's a sense there around mental health. I think we've still got quite a lot more to do in integrating our community mental health transformation work within the neighbourhood health model, and also children and young people. We have family hubs in many parts of the North East and North Cumbria, and probably seen in the media over the last couple of days, will we start to see a return to the kind of Sure Start model, which had a strong evidence base and demonstrated good outcomes. Whatever happens there, I think again neighbourhood health needs to make sure that we wrap up our approach to children and young people as well. Again, section 4 just continues to set out that case for change and also looks at some of our projected population data. It won't be a surprise to us how our population ages. It won't be a surprise where we see increases of presentations of frailty and comorbidity requiring hospital services. So bearing in mind we're talking about a 10-year plan, what can we do now with these client groups that really helps us model the need for treatment services in the future as well. Section 5 will just expand a little bit on this, providing a bit more detail on that population of focus, and again brings in those metrics and indicators that we would consider to be key in determining success, and again framing it within that wider urgent and emergency care work as well. There's a sense, I hope there, of shared aims and design principles with our partners. And when you look at section 7, which goes into more detail of what's been happening in our different localities to date, a real clear sense that yes, we want a strategic intent that's shared, we want a set of metrics that we're all aiming for to measure success by, but what that looks like should be very ability to be tailored very much to the local infrastructure, historic investment decisions, what we know about our local populations, and you know the clues in the title, isn't it? Neighbourhood. We really need to be looking at ward and neighbourhood level, and particularly around some of our post-industrial and coastal communities where the needs can be very different from some of our urban areas. But our partners really want to build on whether that's local authority infrastructure, community hospitals, and particularly some of what we see through general practice, and including our PCNs and our federations. Section 6, I hope, gives you a sense that the kind of weight behind all of this work, we're really, I think, at the point where we move from that strategic intent to structured delivery. And there's a number of enablers that we've been working on in the background, which I think will help us keep that pace over the coming months. So we've had a commissioning framework in development, and that's going to be one of the key building blocks as we move into that strategic commissioning function in greater depth over the coming months, and that will support the implementation at place. We've also got the workforce development work, so things like our NCOP, the nurses who do our end-of-life training within care home settings, again identifying how we can proactively look at what the needs of our communities are and put the right interventions in. The appendix 4, the slide deck, again at the board development session we went through in some depth the community dashboard that we've developed, and that is a real key enabler for me in terms of the visibility we can put on what are the outcomes we have now, and it really drives those questions around where is the warranted and, more importantly, unwarranted variation in this, so we target our time and effort and our resources in the right place. Again, Graham touched on some of the digital enablers, and that will be really key, whether we're talking about integrated care records. They're already through the frailty network. We can see how the Great North Care Record is facilitating more work across partners and across organisations. And also, we've been on a whole suite of visits to other parts of the system, the country where this is working really well, and particularly making kind of buddy arrangements with things like the Jean Bishop Centre in Hull, which has a really great integrated geriatric and frailty model. I'm sure Jacqueline knows well about that from the days there, and we know that that leads to better outcomes. But what it really demonstrates is this multidisciplinary working is how do we get that across organisational boundaries. Sometimes people get so caught up in who's paying them, which building are they in, which digital system are they using, that the concept of true multidisciplinary and interprofessional working gets lost. So some great models for us to build on there. A lot of work of our engagement with general practice. PCNs and federations are particularly interested in the concept of neighbourhood health providers, which I'll come on to in a moment. But all of that, again, building on what was in section 7, is really, I hope, underpins there is not a one-size-fits-all outcome or model at the end of this. And I think we have to be careful. We don't always think of this as physical hubs or buildings where neighbourhood health is delivered from. Yes, that's a core aspect of our model, but it's as much about how we navigate patients through the system across pathways, and as a set of professionals and organisations do that care navigation for them, rather than expecting them to know which is the right bit of the system for their current and presenting needs. Section 8, I just wanted to spend a moment on really. I think it's really critical that we keep hearing the term neighbourhood health providers used more and more now, and again we know this will be really central in the 10-year plan. And so although it's an emerging concept, what we're trying to do is deliberately shape this through our local lens within our integrated care system. So although it's being referenced nationally and it's probably a little bit vague in definition, I think what we do know about this is it's signalling other parts of the system taking a greater role in owning the delivery of neighbourhood health. So some very early conversations with foundation trusts, with our local authorities around health and social care partnerships. Again, some of our general practice federations interested in this. This, I don't think, is for us to decide and design what that looks like today. We wait to see a bit more of the steer that will come through the 10-year plan. But I think we have to be clear, it's not a new structural layer. To me, it's an evolution of our existing place-based approach, and how do we build on the strengths of our relationships across our organisations. But it will lead us to a slightly different approach over the coming months. So for the key points there, I really wanted to emphasise our role as the Integrated Care Board is about defining that strategic commissioning intent, not dictating the delivery form. We expect neighbourhood health providers to grow out of our existing local partnerships, including PCNs, federations, trusts, local authorities and our VCSE sector. The governance and delivery models will continue to evolve, but that should be shaped locally by the maturity of existing infrastructure and our relationships. And we will continue to work with partners to define those characteristics and outcomes, retaining our strategic commissioning role of a degree of performance and contract management against the outcomes that we've commissioned for. So we'd expect to see some flexibility, not uniformity in there, and I think that will really set the tone with our partners of how this evolves. Section 9 gives you a sense of what those practical next steps are. So we're working with our project PMO, our Programme Management Office, on the more detailed project plan that sits behind this. We will need to finalise and then deploy over the next year the commissioning framework that will support the financial flows. We need to mobilise our support offers on digital, data, workforce, finance and contracting, and then continue our engagement through our local delivery teams and our place committees and provider collaboratives until we clarify that evolving neighbourhood health provider model. So, in summary, I think we've set a clear and deliverable intention. I hope the board would endorse the principles that are in the paper and how we can kind of confidently move this into our next phase. It remains a regional system-wide transformation programme. It's clearly aligned with our national policy drivers. We're already progressing delivery in many areas, and we need to just now mature our implementation infrastructure. It's a bit of a whistle-stop tour, Neil. Chair, I'm happy to take any questions from the paper.
Thank you. Questions and comments then? Rajesh, is that you or Eileen? I can't see where it's put. Yeah, it's okay. Go ahead.
Okay. Thanks, Levi. I think it's an excellent paper, and you've kind of summarised what is still quite an evolving and emerging area, isn't it? Which probably will be the focus for us for the next decade, I think. The question I had was when you came to section 9, which was about the next steps, and they all are, extremely relevant and appropriate. One thing which I thought was lacking there was any information to come back to the board about impact, or was that too early for this year with how all those developments are emerging within the places?
I think the answer to that question, Rajesh, is probably yes and no. I think we can already, where we've got some good integrated work in, demonstrate what we believe are some of the beneficial outcomes. What we've done through the community dashboard, which is included in Appendix 4, is start to, and that dashboard can be drilled down by provider level, by locality level, to give you the much more detailed information, whether that's about our 2-hour community response, whether it's around how the data is being used to map our frailty and some of the outcomes. So it may be worthy, maybe just do a one-off session for others to maybe illustrate that dashboard and how you can drill down to get some of that detail. The no bit, though, I think you're absolutely right, there's still an involvement with partners to a bit more visibility on those metrics on a whole range of conditions at a local level.
Thank you. Lisa, and would you go a bit closer to your mic, please? Just not coming through very well online.
Sorry.
Thank you. Yeah.
Thanks. It's a great piece of work, Levi, and the shift towards much more integrated work at neighbourhood level, true partnership work and bringing in connections and relationships across all sectors is absolutely the way that we need to go as a system. And you mentioned building on the really good work that we've got at place, and the integration at place of the voluntary sector is often really, really good. However, there is still one area in the ICB that doesn't have VCSE membership on the place committee, despite that being mandated, I think, a year ago. And I was just wondering, is there something that we can do to resolve that so we don't build on something that's not actually including probably the most neighbourhood based of all of the partners?
Absolutely, Lisa. So you might think the paper's a little long now, but it was about twice as long before I cut it down. So section 7 has a lot of detail of what we've done in all of our localities, and there are detailed blueprints behind all of that, including the membership and partners who are part of that conversation at the moment. I'll pick up with you directly outside as soon as board's finished, because if there's one area in our patch that is not actively engaged in the VCSE, we'll pick that up immediately tomorrow and make sure that they're round the table having that equal voice in the conversation. So just to I suppose to give you that sense, that commitment is real. So where it's not happening, I'll make sure it does. Thank you.
Thank you.
Christopher.
Thank you, Chair. Levi, thanks ever so much for the paper. I actually think it's quite exciting moving into integrated neighbourhood health. What I wouldn't like to see, and I'm pleased you touched on the fact that it has to be flexible depending on the various communities of place, is that we end up wrapping something around local authority infrastructure and added the piece of work around community mental health, and what works there may not work for other models that we are trying to implement. And I would hope that going forward that we got the assurance that we were looking at through a lens of the accessible information standards, because a lot of the population that we want to help, like, you know, they are not able to access services currently. Well, we have the opportunity to change that, because there's a lot of people with long-term conditions, a lot of people suffering from digital poverty, lots of things like that. So it's really whether or not we can continue with that co-production as we move into delivery once we develop the blueprints.
Thanks, Christopher. Just picking up the point on local authorities. I think to some degree it will wrap around where it's the right thing to do. So I think what local authorities have brought to this conversation in particular is that sense that when we talk about communities, the local authority experience around leisure and a whole range of other services, housing, it brings a richness that means it doesn't just have a health focus on our community. So there's a balance to be struck there. In terms of mental health, I mean, you'll be familiar, we've got the great example in Hartlepool of a really community-based approach. And again, I think our responsibility is to help individuals navigate which bit of the system will meet, rather than them finding their own way. I do think we've maybe in the last year or so lost a bit of that national messaging around health inequalities, and you know, levelling up is not a term you hear very much now, but I think what part of the intent here is again using the data to say where do we know we've got further to go for our population, and that should drive where we prioritise both any investment but also the pace behind the change. I think the accessible information standards is a helpful point. We've picked up the digital inclusion. There's probably a bit more to think through there on that aspect, Christopher.
Thank you, Chair. Lever, thank you for the paper. It strikes me that we've got to strike the balance between being prescriptive on a sort of more outcomes-based approach to nurturing local innovation and, of course, building on all of the really excellent work that's happened in many places across the ICB. Having said that, I think we can anticipate when the new 10-year plan is published a very significant section in it for integrated neighbourhood health, and it being seen as the future way in which the public will access healthcare as the first port of call. So, and then I'm mindful of the various things that need to be in place to support this. We need good data sharing agreements, IT systems, estate, leadership. There needs to be that shift in resource over time. I can't imagine that there's going to be a significant pot of new money available to build on and develop these services. And whilst we've got some really good services that exist at the moment, we need to put more resource there. So I think there's something for us as a board that we are going to have to spend quite a bit more time on this, and we're going to have to balance, I think, the approach of being very clear about a framework and how we commission these services alongside the partnerships that are required and supporting the good work that's happening already to be nurtured and develop further. But I think it will need to develop further, and I suppose I'm not sure we can fully leave it to we're doing this already and it will just continue to happen. I think we're going to have to sort of strike the balance on how we commission these services in the future and what that will mean in terms of our expectations of providers of neighbourhood health, and also keep an open mind about who those providers of neighbourhood healthcare services can be as well in the future. There may be a greater role for some providers than there is at the moment, and the other way as well.
Yeah, and we've been very much, I hope, trying to take a twin track. We don't want to lose the foundations we've got now. We want to keep growing and expanding those, whilst I think you're absolutely right saying, however, there's a slightly different strategic approach for the future. So I think, how do we run those two bits in parallel and find the right point of convergence? Yeah.
Thank you. Sarah.
Thank you, Levi. Very insightful presentation, very valuable. I just wanted to go along the veins of what Sam just said. The two questions that were running through my mind is, one, how ready are we for neighbourhood models? And I asked that question based on the fact that we know that relationships at place-based between general practice and trusts have not been as robust as they can be or will need to be moving into the future. But also just thinking about that strategic commissioning role that we will move into as an ICB, is our role to facilitate using a framework, as Sam has said, or would it be to manage negotiating those relationships? And I truly hope it's the first, not the latter. So yeah, just some observations.
If I take your second question first, I think you're absolutely right. I think what we need to do is be clear what the standard is that we judge success by. And we will have a role, I think, in monitoring that and holding to account where we think it's adrift. But really, it's about being the right glue to join all those different parts of it together. And again, so set out a really clear strategic commissioning framework, be clear what those digital enablers are, what are the metrics of success. And just picking up Sam's other point around investment, I agree, there's not going to be a new pot of money, but we've already seen it, as David illustrated, through the financial plan. How do we help shape what we currently spend as a system now to move from secondary to primary in other ways? And you know, we've talked about ARI hubs. Respiratory will probably be the next area we'd look at. And how ready are we for this? I think that maturity is different in different places. You know, without naming names, there's a couple of localities who are knocking on my door every day saying, can we take this on now? We're ready to go. But we just need to maybe, when I say pause, we just need to be clear what we are ready to go on, which is why I think that commissioning framework will be so key. Others, I think, are still just kind of navigating how do we bring the partners. My only anxiety in this is that we do not let whoever comes forward first have the loudest voice in those conversations. And I think that's one of our responsibilities, is how we convene the right range of partners, you know, picking up your point, Lisa, as well about VCSE, that doesn't weight it too heavily one way or the other.
Neil.
Just a quick comment, really not a question. I think for me, when you read this, it very much talks, and it's a national framework. I think neighbourhood health is much more than what is in here. It describes to me an integrated health care service offer, mainly for frailty. And that may not be what is the priority need for every single neighbourhood. So I think as we develop our model, we just need to be smarter about what that actually means for each of the neighbourhoods. I think this element would have to be there. And I think that the big focus of this all appears to be, yes, moving that care from hospital into community, which I get. I just worry if it just completely focuses or it embarks on looking at frailty as the only application of this, then we'll miss a trick. There's a comment, not a question.
Thank you.
I think Neil has summed up broadly what I was going to say. I did hear, I'm very positive about this integrated neighbourhood health, and I heard you, Levi, say that, you know, you've got a sort of exemplar area, but it is wider than frailty in older people. And you did refer to younger people and family hubs and mental health provision. On the test area of people who were over 65 with frailty, that was one area of divergence from when we had that board development session, because I think there was a really interesting conversation there about there are some parts of our population where people become frail at a chronologically earlier point in their lives. So people with alcohol and substance use problems, with lots of other lived experiences, they can become physiologically frail in their 50s. And we know that when you find population mortality rates, you know, really plunging in parts of the country, we know it is these very highly vulnerable groups of complex needs. So it's maybe kind of a nuance on what Neil is saying. I get the concept and I get having a test area, but even within that area around frailty, it is focused on later life. And we know that frailty is an issue for people who are not always post 65, if you see what I mean. And just one other thing I would want to say is that, again, echoing Neil, different areas will have different populations where they think the need might be most. And, you know, obviously, if you're looking at areas where there's intimate partner abuse, particularly domestic sort of violence, there are certain areas where when women's health is at the fore, you know, the integrated needs of women who are often carers in families who experience intimate partner abuse and violence, you know, that's an area where integrated care is absolutely needed. So I'd like to make sure that that doesn't get lost on the list of areas we might focus upon.
And I just note those are all well-made points. Frailty is where the data drives us at the moment, and I hope that comes through in the appendices. But absolutely, what we've picked up is the need to go much broader than that. So when we look at our high-intensity users, there's often those degrees of mental health, substance misuse, a number of chronic conditions. So it's really helpful feedback. I'll feed that back into the work plan, and we'll continue to refine it.
Thank you. I don't see any other comments or questions except a few legacy flags here and there, but no. Okay. So we don't have any more questions from the public.
I can confirm we have not.
And checked at the beginning, nobody's got any other business, so with the board secretary's approval, we'll implement the ICB's early release scheme and let you go. So thank you.